new venture of KFOG under the presidentship of Dr. Kunju Moideen, KFOG Edge webinar series. Today we have the maiden program of the Academic Committee of KFOG involving Thiruvananthapuram, Adur, Kollam and Kottayam Society. We are honored to have amongst us Dr. Rajashekaran Nair, our patron, national faculty, Dr. Sundari and other renowned faculties for the event. There are indeed many exciting topics in the pipeline and many distinguished speakers ready to share their knowledge through this platform in the upcoming months. Before we begin the formal inauguration ceremony, let us unite our minds in the presence of Almighty to seek His blessings for a few seconds. Let us now begin the inaugural ceremony. I invite Dr. Sujitra, President-elect 2025 and the coordinator of KFOG Edge webinar series for the welcome address.
Good evening to all. Can you hear me, please?
Yes.
Yes, madam.
Yeah, we can hear.
Good evening to all. This is a historical moment because it is the first of this kind of series, that is the Edge, which has been the brain behind this Edge, this knowledge series involving all the zones, is none other than our KFOG president, Dr. Dr. Kunju Moideen. He is a vibrant young person with a lot of new ideas, and he has activated the entire KFOG. So welcome to you, sir. I now welcome Dr. Rajashekaran Nair, sir, the patron of this program. And sir, as we know, is a versatile artist. He can make skits, he can draw pictures, he can present in a very vibrant way. So welcome to you, sir, to this program. I now welcome the Secretary General of this program, Dr. Subhash Malya, the young Turk who's ever smiling. He has gone to Dubai to do a presentation at the international level. So welcome to you, Subhash, Doctor. And now, our chairperson, Dr. Rajesh Ravi, who has been doing a lot of groundwork to make this first ever KFOG Edge series a grand success. So welcome to you, Dr. Rajesh Ravi.
Thank you.
And we have our expert, Dr. Sundari Nandyala, Professor ONG from MS Ramaya Memorial Hospital. Welcome to you, madam. We are so happy to have you here.
Thank you.
Then, of course, we have our chairpersons, Dr. T. Uma, Dr. Sati Murari, Dr. Ansi Jacob, the three chairpersons who are going to look after all the presentations, etc. The presidents of the Zone 1, that is Dr. Sujamol Thomas, President of Trivandrum ONG Society, my own professor, Dr. Prasanna Kumari Madam, President of Adur, and Dr. Annama, Kollam ONG Society, Dr. Beena Kumari of Kottayam ONG Society. Welcome to you, madams, all the presidents and the chairpersons. And the stars of today, those are the speakers, Dr. Kala Pramod, Dr. Rani Lakshmi, Dr. Dhanya L, Dr. Prasanna Kumari, Dr. Sangeeta Menon, and Dr. Deepa Matthews. We're all waiting to hear all about this very common, but very, very often a problematic thing, that is the episiotomy. So over to you, Dr. Rajesh. You get on with the proceedings. Thank you so much for giving me this privilege of welcoming the audience. And a big welcome to all the audience, all our colleagues who have gathered here today. Without your presence, this webinar would not have been possible. Thank you once again.
Thank you, madam.
Thank you, madam, for setting a delightful tone for the rest of the evening. May I now request Dr. Kunju Moideen, the cornerstone of our organization, President KFOG, for the presidential address.
Good evening to all. Respected Chief Guest, dearest Rajashekaran Nair sir, other dignitaries, the presidents of various societies, Secretary KFOG, Dr. Subhash, the chairperson of Academic Committee, Dr. Rajesh, the President-elect, Dr. Sujitra Sudhir, and the state coordinator of this KFOG Edge program, all the faculties, delegates. At the outset, I must congratulate the program organizer of today's webinar, Dr. Rajesh, for this wonderful webinar scheduled on episiotomy, because there is an overwhelming response for this program. I could see around 400 plus people have registered for this webinar. And that's a big number considering the number of conferences and CMEs happening all over India. And this KFOG EDGE program, it has been designed so that all the committees of KFOG will be organizing 3 webinars each. Anything? All the committees will be organizing 3 webinars each that will be dealing with all the latest topics in the particular domain. And we are starting with this academic committee and with a very basic topic of episiotomy, which is relevant on yesterday, today, and tomorrow. And all the newer things with regard to the episiotomy, the indications, complications, techniques, video demonstration, and moreover, what are the evidence-based practices in the particular topic will be discussed throughout this webinar. And I would like to mention the role of Dr. Sujitra Sudhir ma'am, the President-elect of KFOG and the State Coordinator of this EDGE webinar series. Madam has wholeheartedly taken over the assignment of the coordinating all the committees and to have all these webinar programs be materialized on the pre-scheduled dates. And we all think Madam is the best and the right person to do that assignment without any hurdles. And I also express my sincere thanks to the STR team who have provided this webinar platform. And I don't have words to support the efforts of Dr. Subhash, who have taken all the efforts to coordinate all the societies, all the presidents and secretaries of all the societies to have this program happening on this particular date on today evening at 5:30 p.m. So I must congratulate our secretary, Dr. Subhash, for his vastful experience having organizing similar programs in the past. And with these few words, I express my best wishes for this program, as well as to have a great success for all the delegates who are participating in this program. Thank you.
Thank you, sir, for your valuable insights. I take great pride in inviting our guest of honor, Dr. Rajashekaran Nair, to formally inaugurate this program and deliver the presidential address.
Inaugural.
Sorry, inaugural address.
Sir, unmute cheyanam, sir.
Okay, so already the presidential address is over. It's only an inaugural address. Respected KFOG President Dr. Kunjumoideen, Secretary Dr. Subhash Malia, Academic Committee Chairperson Rajesh Ravi, and the coordinator of the program KFOG EDGE webinar series, Dr. Sujitra Sudhir, and all the presidents and secretaries of societies, of various societies in Kerala who are logged in, and my dear friends, and the distinguished faculty members and my dear friends. I am really glad to see that the first topic selected by the KFOG EDGE webinar series is episiotomy. As all of you know, episiotomy is the commonest intervention in obstetrics, even though it is expected to facilitate delivery and to reduce the sequelae on the perineum, both short-term and long-term. I think most of the recent studies indicate that it's a procedure of doubtful value and should be kept to the bare minimum, and it should be done as a highly selective procedure in suitable circumstances. And today fortunately, we have got a galaxy of speakers led by none other than Dr. Sundari, who is a close friend of mine. And all of them will enlighten us on the different aspects of this particular problem. And I'm immensely happy to inaugurate the webinar and hope that it will be extremely useful to the audience. And I wish to thank all of you for giving me this particular opportunity to inaugurate the webinar, and wish all success for this webinar series. Thank you all once again. Thank you very much.
Thank you, sir.
Thank you, sir. May I now invite Dr. Sundari, former professor of OB-GYN, MS Ramaya Hospital, Bengaluru. Her specialty involves in cervical cancer prevention and high-risk pregnancy. She's also the founder of Mahadi Trust, an NGO working towards cervical cancer prevention in Karnataka. Madam, I request you to deliver the felicitations.
Hello, good evening, all of you. Am I audible?
Yes, madam.
Yes, madam.
At the outset, I thank the organizers for giving me this opportunity to take part in this prestigious webinar series. I understood that the first of its kind. Now you are starting it. It's my privilege to be a part of this first webinar of the series. Now, to all of you, Dr. Kunju Moideen and Subhash, of course, very active person, I know him. Rajiv, he was constantly in touch with me for this. And Dr. Suchitra and the coordinator of KFOG Edge webinar series. And then all the presidents of all the societies. I really congratulate you for taking up this wonderful webinar series. And then starting with the basic subject like episiotomy, which I don't think any webinar has done so far on episiotomy alone. It's a novel idea, I tell you. Episiotomy, as Rajshekharan sir said, sir, good evening. As Rajshekharan sir said, episiotomy is the commonest surgical procedure. Every obstetrician will be doing it. Most of the postgraduate starts with their surgical skills by doing the episiotomy. That is the first procedure, probably they will say. Yet, we have a lot of gray zones and a lot of controversies as far as episiotomy is concerned. The main thing is selective episiotomy, we say, not the routine episiotomy. Is it applicable to even Asian women? Allowing perineal tear is better than giving a deliberate cut on the perineum. Do we have to say take a separate consent for episiotomy apart from taking a consent for the labor? I think these are all the few controversies we do have when we deal with episiotomy. I'm sure the discussion involving the galaxy of the experts today, they will be dealing with all these controversies and the dilemmas. And I'm sure it will be a very interesting and informative to all the students. Students, please, you be careful and listen to them, not just switching on your videos and walking around, because this is a very basic, but yet very, very important subject for all of you. I wish KFOG Edge webinar series all the best in all their future endeavors. And again, I thank you for involving me in this prestigious webinar series. Thank you.
Thank you, madam. Thank you, madam. May I now invite Dr. Prasanna Kumari, madam, President of Adur OG Society, to speak a few words.
No, madam.
Prasanna, madam, is online.
Yes, madam.
Actually, I'm the post-operative period after my rotator cuff injury repair. I was having severe pain, but when Rajesh said it is episiotomy, I thought I will speak on episiotomy. And I'm glad that they have started the webinar on episiotomy, which is actually my favorite subject. And I wish all obstetricians should learn how to avoid episiotomy, how to perform an episiotomy, how to avoid complications, and how to treat if there is complication. So I am very happy, and I wish the webinar will be very useful to the obstetricians of Kerala.
Thank you, madam. I call upon Dr. Sujamal Jacob, President, Thiruvananthapuram OG Society, to felicitate the gathering.
Hi all, once again a very good evening to all who have gathered here in this webinar. The guest of honor, Rajshekharan sir, the expert who has joined us, the professor who has joined us from MS Ramaya, Sundari madam, various senior faculty members, the KFOG team, Dr. Kunju Moideen, Dr. Sujitra, Dr. Subhash, Rajesh, and all my dear colleagues and friends. In fact, this webinar, KFOG Edge webinar series, which is starting today, I feel that it's a novel idea. of a webinar. In that, we have been hearing webinars with 2 or 3 different topics dealt with different individuals. But here is a webinar which is starting today, which is dealing with just one topic, which has been split into 6 different, given to 6 different individuals. So that itself means that it's going to be very interesting. And also, I feel it's going to be more informative in that each person who is given only 15 minutes, he'll try to gather the maximum information about that aspect which is allotted to him. So I feel it's going to be very interesting for the next 2 to 3 hours. And all the more participation can be ensured by this. In the South Zone itself, 6 societies are involved. And I think one member from each society is given an opportunity to talk on this platform. So in that way also, this KFOG Edge webinar is going to be unique. So I wish all the best for this KFOG Edge webinar series. And today we are beginning with a very basic topic, that is episiotomy, which not only the postgraduates, but also all the senior members will be benefited from each and every aspect which is going to be discussed today. So all the best for today's webinar and also all the series which is going to come over the next 1 year. Thank you.
Thank you, Madam. May I now request Dr. Beena Kumari, Madam, President, Kottayam ONG Society, to speak a few words.
I think Veena Madam has not joined. Veena Madam and Anama
Okay.
Madam has not joined.
Anama Madam.
Madam has some
Okay.
emergency. Madam, call.
Okay. Then I shall call, may I now invite our vibrant secretary of KFOG, Dr. Subhash Malya, to speak a few words. Sir is online.
Yeah, of course, I'm here. I'm here.
I didn't see you, sir.
Respected President Kunjumadin sir, respected Chief Guest Rajshekaran sir, and all the senior faculties. I wouldn't take much of a time between this lecture. Again, I would like to extend my heartfelt thanks to all the presidents, secretaries of all the societies and all the faculty for being here. Again, I would like to thank Dr. Rajesh for taking all the efforts, and I wish him the very best in his success and the whole. Again, last but not least, Sundari Madam, thank you very much for accepting our invitation, Madam. And I wish the very best. And also, I would like to thank Astria for the wonderful opportunity they're given and the platform that they're given. Kunjumadin sir, thank you very much for arranging this also. Kunjumadin sir has been very gracious in giving a lot of credit to me. I do believe that I do not deserve much of it. It's all sir's efforts. Sir has been very gracious enough in giving me that. Thank you very much. And I wish this committee and every other committee to come forward with many such programs and to take KFOG to even greater heights than what our seniors have already given us. They've given us a good platform. We'll take it even higher. Thank you very much. Thank you.
Thank you, sir. To present the vote of thanks, I would like to invite Dr. Rajesh, Academic Committee Chairperson. Over to you, Dr. Rajesh.
Thank you. Actually, KFOG Edge webinar series is a plan put forward by our President Kunjumadin sir. And actually, half of the work was already done by sir before handing over me the program. Though it was a short notice, I had not much work to do rather than inviting people and coordinating the event. So, first of all, I want to thank Kunjumadin sir for the master brain being behind this and putting all the effort and getting the platform for the program and everything. So, thank you, sir. Thank you for being the leader which we needed. Thank you, sir. I also want to thank our guest of honor, Dr. Rajshekaran sir. As we all say, one of the pillars of KFOG. We wanted sir to, since it was from the South Zone, we thought sir is the apt person to inaugurate the function and being the torchbearer of many of our programs. Thank you, sir, for obliging on a short notice. Thank you, sir. When thinking about the faculties, we had all these faculties from Kerala, and one of the programs which COVID donated was this webinars. And I still remember coordinating the first webinar in 2020 after the COVID. It was in June or July, and it was a PG teaching program. It was by Calicut Society, and I still remember Sundari Madam was one of the first teachers who had the case presentation done, and I was actually doing my DNB at that time, and I was abstruck by the teaching and the how fantastic teacher madam was, and it was a CSOX class. I still remember that class. So when we were thinking about a episiotomy topic, which is a PG topic, I had no other option. So I called madam, and madam, though she is having another program today, readily agreed to the for coming as an expert for the program. I thank you, madam, for gracing the occasion as well as for being the expert for the program.
Thank you, Rajesh, for your kind words.
Thank you, ma'am. I thank Dr. Sujitra madam for being the coordinator of the EDGE program and giving the inaugural address. Thank you, madam. I thank my dear mentor and friend, Dr. Subhash Malia, for being such a support to me all through the program when there was some hiccups in between. I thank you, sir. I thank all the presidents of the societies. Actually, we were supposed to include Alpura Society also, but there was some confusion. So we are going with the 4 societies, Trivandrum, Kollam, Adur, and as well as Kottayam Society. I thank all the presidents and secretaries of the societies for all the supports. I thank the chairpersons for today's program, Uma Madam, Sadhya Madam, and Nancy Madam, who are here with us. I thank you all the chairpersons, as well as there are 6 different subsets for the program, 6 different topics for the episiotomy. We have 6 excellent speakers for giving the talks on these topics. I thank Kala Madam, Rani Madam, Danya Madam, Prasna Madam, and Sangeeta Madam, as well as Diva Madam, for taking the pain on a short notice. We only gave them 1 week, but still they all came up and agreed readily. Thank you, Madam, and a special thanks to Prasna Madam, because Madam Madam was told me I am going to have a surgery, but this is an episiotomy topic. This is a teaching program. I will surely come. I want to come. That is what Madam told. I want to come. Whatever, I will take one painkiller and I will come. That's what Madam told. So special thanks to Madam as well as all the faculties for giving the talk. I thank all the delegates who have joined. We have now up to around 200 participants now. We expect more in the coming the short period. I thank all the delegates. I thank Astria for the technical support and KFOG Nexus for the technical support. I hope I didn't miss anybody. With that, I thank once again everybody, and we'll go to the scientific session. Thank you.
Without further ado, we are moving on to the scientific program of the day. Our expert member for the scientific program is Dr. Sundari, and we have 3 chairpersons, Dr. T. Uma, Additional Professor, Department of OBG, Trivandrum Medical College, Dr. Sati Murare, Vice President, KFOG, past Chairperson, Academic Committee of KFOG, Dr. Ansi Jacob, Professor OB-GYN, Travancore Medicity, Kollam. I request the chairpersons to introduce the speakers. First, I invite Dr. Uma to introduce Dr. Kala Pramod, our first speaker of the event.
Thank you so much, KFOG EDGE. I'm so happy to be in the first session itself. Thank you, President Kunjumoideen sir, dear friends Subhash and Rajesh, for having given me this opportunity. Much respects to Rajshekharan sir, Sundari madam, senior faculty, Sujitra madam, Prasanna madam, Sujamol madam, who have all been my teachers, and senior faculty like Beena Kumari madam, Sangeeta madam, and Annama madam, for having given this opportunity. So the topic episiotomy is actually something in our growing days, like half of the faculty had an opinion that a clean-cut episiotomy is best repaired, and there was another set of faculty who taught us that chair which is made naturally is best repaired. Anyway, let's hear from the experts what they have to say. I introduce Dr. Kala, the first speaker for the day. She's a good friend of mine. She's a dynamic secretary of Trivandrum OBG Society. She's a professor of SAT Hospital, and she holds much interest in high-risk obstetrics and adolescent gynecology. I invite Dr. Kala. Welcome, Dr. Kala, to deliver your talk.
Respected chairpersons, the expert, the respected KFOG team, and all the senior members who have logged into the CME. Let me first of all congratulate and all the best wishes for the KFOG EDGE series of CMEs. And I really congratulate them for selecting one of the basic topics in obstetrics, that is about episiotomy. When Rajesh asked me to, am I audible?
Yes, madam.
When Rajesh asked me to present the topic Understanding Episiotomy, I was wondering what to talk for 15 minutes because almost all aspects were divided among the different other colleagues of me who are presenting the different aspects. And he told me to present about the history of episiotomy and the definition. Thanks to Rajesh, for the first time in my life, I researched about the history of episiotomy. And this was really a new information for me about the history, because all of the histories we actually researched this, I haven't so far looked into the research of episiotomy. Okay, so first of all, for you the topic proper, the episiotomy is one of the most common surgical procedure and it's one of the most simple surgeries in obstetric practice worldwide. And even though we say that it's a very simple surgery, any faulty technique, or if you are not practicing asepsis or an improper suture material that has been used for episiotomy, all these can lead to problems not only in the immediate postpartum period, but it will be creating a long-term morbidity. And when we research, when the rates of episiotomy vary in different parts of the world. And India, not much studies, recent studies have been seen about only some localized studies regarding what is the prevalence of episiotomy. Actually, it is very low in some of the countries like Netherlands, UK it's low, and US it's slightly more. In India, still in many of the centers it is high, and the rates vary depending upon several other factors also. So for a long time, when we think about episiotomy, we always think it is a first surgical procedure that during our MBBS days, all of us performed, where we learned the art of suturing. And I even now remember many of the house surgeons doing a perfect art. They are learning the suturing technique by suturing episiotomy. So when we go to history, the labor is considered to be a physiological process. But time immemorial, everyone considers delivery as a painful procedure. Even in the Bible, it is stated, it will greatly multiply the sorrow through conception, in sorrow that brings through children. And episiotomy will be definitely adding to this pain of this labor. In some of the materials, episiotomy is described as an unconscious cut. But in some others, it is described as a little snip. No, it's not at all bothered about what is episiotomy. When I searched into the history, the earliest record of perineal care in labor, it is said to be given by Soranus. He applied warm clothes and lipid solution to the perineum. And in the 11th century, there was some reference about giving perineal support during delivery with linen clothes. And the first reference of episiotomy is obtained in 1742. The Sir Fielding Out, he was a midwife in UK who performed in US. He performed the first episiotomy. And from 1980 to 1920, it became more popular in US because it was advocated by another midwife, Joseph Daly. And 1940s to 1980, episiotomy became a routine practice in US. But in UK, it was not popular till 1960. After the 1960, the trial of the active management of labor by Driscoll et al. Came in, and it became very popular in UK. So in UK, there were different standards in different midwifery units because that's the main route of delivery in UK. So one of the aims is Association for Improvement in Maternity Services in UK. In one such midwifery center, one midwife stated that episiotomy is mandatory on all primary gravida. It was only in 1976 that another newsletter carried an article describing episiotomy as an unconscious cut, questioning the use of a routine episiotomy. And in it even described that episiotomy is given to medical students for learning suturing technique, and such a description is given in that article. And it was Sheila Kitzinger who first exposed the trauma women suffered by one of her articles. In 1982, there was an RCT in UK which was published in 1984 by Jennifer, where the benefits for the routine episiotomy was questioned. And 1985, WHO stated that systemic use of episiotomy is not at all justified. And 1996, they recommended an episiotomy rate of 10%. And then came the Cochrane Systematic Review in 2012, where definitely it stated that restrictive episiotomy has got a number of benefits when compared to a routine episiotomy. And from 2004 to 2017, we definitely see there is a reduced rate in the episiotomy rates, especially even for operative vaginal delivery, it's reduced, and even for a spontaneous vaginal delivery, and in majority of the countries, it has dropped. And in our institute, which is an academic institute, actually, when I looked into the rate, it was coming to about 80% for the past year. I think it's good for an academic institution in India, especially a referral center. And so this 2018 WHO made another recommendation that it cannot be this the rate accepted rate. We cannot fix it as 10%. It has to be identified by the obstetrician in selective cases. And as all of you know, there are so many factors which affect the rate of episiotomy. And the most important is parity. Usually it may be needed in a primary gravida, then insurance services, then the geographical area, especially more in urban areas, the type of the hospital, whether it's an academic center or a private hospital, then private practice, and there are when we are using risk-reducing methods like a applying balm, perineal massage, we can actually reduce the rates of episiotomy. All this data will be shared by Dr. Sangeeta Madam, and I am not encroaching into her area. So coming to the definition, it's a planned incision on the perineum and the posterior vaginal wall during the second stage. Actually, the term episiotomy is a misnomer because the term means cutting the pudendum, but that means external genitalia. Here we are actually cutting the perineum, so it should be ideally called a perineotomy. And the purpose is to enlarge the vaginal introitus to facilitate easy passage of the fetus and avoid trauma to the perineum. Technically, it's a second degree perineal tear, especially a mediolateral episiotomy. The objectives are to enlarge the vaginal introitus to facilitate easy and safe delivery, to minimize overstretching and rupture of the perineal muscles and fascia. And it is now recommended only for selective cases, which will be discussed soon. And the advantages proposed during the time of the routine episiotomy was that, as Uma has told, a clean cut injury is easy to repair than a lacerated cut. It helps to cut short the second stage. It reduces the strain on the pelvic floor muscles. It reduces prolapse and incontinence, but all were found to be wrong in subsequent trials. And for the fetus, it reduces the intracranial injury. It's indicated in shoulder dystocia. And I hope all these things, the types of episiotomy, etc., will be discussed under the techniques, median, mediolateral, J-shaped, lateral. And this is a very important thing, the timing of episiotomy. It should never be too early or too late. The ideal time is when the presenting cord is coming out and it is not receding after a contraction where the perineum is thin. When we are giving it too early, there will be more bleeding. When you are giving it too late, there can be excessive stretching, and so the actual benefit will not be obtained because lacerations will be produced. And this is a very common undergraduate question: what are the structures cut during episiotomy? I hope all the muscles of the perineal floor, the superficial and deep transverse perineum, bulbospongiosum, the part of the levator drainage, except that ischio-cavernous will not come in this. And then the posterior vaginal wall, the fascia covering this muscle, the transverse perineal branches of the pudendal vessels and nerves, the subcutaneous tissue, and the skin. These are the structures cut. Okay, thank you. Thank you for giving me an opportunity to present in this first KFOG Edge webinar series.
From everything. Yeah, it is very interesting to know the history of episiotomy. She brought in from where the perineum is talked about, and then the perineal care and the cut on the perineum, everything very nicely she has brought out, Dr. Kala has brought out. I think, to be frank with you, I have never read the history of episiotomy. She brought it out beautifully. It is a nice. One thing is, now they say the perineal massaging, if you can teach the woman at the term before delivery for few weeks or so, if they start doing the perineal massage, probably perineum can become lax and the tears will become less.
Yes.
That's what it is said now. I do not, they say, no, as you said, the perineal support and a warm, this one for the perineum, massages for the perineum and all you said. But in the house, if they can do perineal massages with oil or something, 2 weeks before the expected date of delivery, when they come for labor, probably the perineal tears can be lessened. That's what one more thing is promoted now recently.
We have our next speaker, Dr. Rani Lakshmi. She is talking about the indications and contraindications. She is the Associate Professor of Kottayam Medical College. And also she was a past secretary of Kottayam Society. So I think we Over to you, madam. Dr. Rani Lakshmi, madam, it's out to you.
Thank you, Ansi. At the outset, let me thank the KFOG organizers for giving me an opportunity to present before such stalwarts such as Sundari Madam, Prasanna Madam, Rajashekaran Sir, and also all the best wishes for the new team, Kunju Moideen Sir, Subhash and Rajesh, for taking such an event to us. Let me share the screen, Rajesh.
Yes, ma'am.
Yes. Am I audible, Rajesh?
Yes, madam. Yes, madam. Loud and clear.
So I had previously excused myself from Rajesh that I have only a few things to say. As Kala Madam said, most of the topics are overlapping, and actually I have to copy from Kala Madam and other madams. So my topic is all. I have only a few slides, 10 slides. So this definition was already told. The definition of episiotomy. Episiotomy is otherwise known as peritoniectomy, but the two terms are not synonymous actually. Actually, episiotomy is an incision on the pudendum, that is external genitalia, whereas peritoniectomy is an incision on the perineum. Actually, we are doing a peritoniectomy. For practical purposes, we will be discussing today's term as episiotomy. So, revising the definition once more, it's a surgically planned incision on the perineum and the posterior vaginal wall during the second stage of labor to facilitate vaginal delivery. So, today's topic is what are the indications and contraindications of episiotomy. So, as we go through the history, we can see, as Kala Madam said, it was a routine practice. Once it was introduced, it was a routine practice to give episiotomy for all delivering patients. And there were so many controversies. There were so many unnecessary episiotomies leading to unnecessary trauma and morbidity among women. So there was a different studies going on whether it should be selective or routine. So I have selected only the latest studies. You can see that the WHO study of 2018, which included a Cochrane review of 12 RCTs, recommended that routine or liberal use of episiotomy is not recommended for women undergoing a spontaneous vaginal birth. Coming to the NICE guidelines and the RCOG guidelines, both of them recommend that an episiotomy should only be performed if there is a clinical need, such as an instrumental birth or suspected fetal compromise. That's a NICE guideline. And again, coming to RCOG, the RCOG guidance on the management of third and fourth degree tears also recommend that an episiotomy should be mediolateral and should only be performed if clinically indicated. And the cutting angle was advised to be 60 degree rather than the 45 degree, which is usually recommended. So the Cochrane review that included the 12 RCTs compared the selective and restrictive use of episiotomy, and they compared several outcomes, maternal outcomes in terms of short-term, long-term morbidity, the dyspareunia, and the fetal and neonatal outcomes regarding the ABGA scores. And the turned out to be, the results was that in terms of short-term morbidity, the evidence suggests that a policy of selective or restrictive episiotomy may reduce severe perineal or vaginal trauma, mainly the third and fourth degree perineal tears, compared with the routine or liberal episiotomy. The other morbidity sectors, there was no efficient data to recommend the long-term morbidity and the decrease in pain, decrease in dyspareunia, and the low ABGA scores. There were no evidence to suggest, compare both selective and routine use of episiotomies. Coming to the indications of episiotomy, we are all studying from our undergraduate classes that indications include a rigid perineum, one with a short perineum, the distance between the posterior fourchette and the anterior inner margin. When they have a short perineum, episiotomy is indicated. And when you are anticipating a perineal tear, we're expecting a big baby to be delivered, you have a persistent OP position, you need manipulations as such as a shoulder dystocia is anticipated, or you are going to deliver a breech where manipulations are required. In such cases, you will put an episiotomy. Also, you all know in operative deliveries, we may need to put an episiotomy. And you all know that episiotomy shortens the second stage of labor. So in a prolonged second stage of labor, or if there is a fetal distress, you can always put an episiotomy. So I couldn't find much contraindications for episiotomy. In an interesting or funny thing that could be found out was that episiotomy cannot be performed without consent of the patient. I really wonder how many of us are taking a consent before putting an episiotomy. And I actually think none of our residents are, most of our residents are not taking a consent. And I think this will be a take-home message that episiotomy cannot be performed without the verbal consent of the patient. They do not say written consent, but episiotomy cannot be performed without the verbal consent of the patient. And there are relative contraindications like IBD or inflammatory bowel disease, severe perineal malformations, and episiotomy again should not be performed unless the vaginal delivery is considered to be possible. So in this Cochrane study, which included 12 RCTs, they also inquired about the acceptability of this procedure among the different women. About 6,000 women were questioned, and in the qualitative systematic review exploring women's and providers' views of intrapartum care, these women answered that they were poorly informed about the reason for performing an episiotomy, and they were actually rarely asked for their permission. So I think that's an important point to take home, that we should actually, in our antenatal counseling or during the intrapartum, we have to counsel them about the need for an episiotomy. And if at all an episiotomy is put, a verbal consent has to be taken. So regarding one more sentence about patients having a previous anal sphincter injury, do they need an episiotomy, or do we have to do an elective cesarean for those patients? In that cases, the recent studies suggest that we have to do an anal pressure measurement and an ultrasound. And if she is asymptomatic, she can 95% chance of having a successful delivery without a repeat sphincter involvement. If she has a secondary sphincter repair or a trauma is anticipated, or she has persistent symptoms, it is better to go for an elective CS. So that's all. Thank you.
Thank you, madam. Actually, though madam told, say, small topic, I actually think this is the most important topic in this session, because when during our internship period as well as housency period, I remember in Calicut, housens were taking delivery mostly, and we put episiotomy for everybody. We shift the patient to second stage, we put an episiotomy, and then we wait. So there was, we all believed that it was indicated in all patients. For every patient, we should put an episiotomy. And when we were reading for post-graduation, actually I was confused, because every time instrumental delivery is discussed, there will be a sentence, put episiotomy. Shoulder dystocia, there is a sentence, put episiotomy. And I was confused. Anyway, we are putting an episiotomy. Why there is a special mention about put episiotomy in shoulder dystocia, put episiotomy in a breech delivery? So then only once the person who actually threw light to this was my professor P.V. Joseph. He had a private patient. It was a primigravida term patient, and usually he doesn't come to labor room for delivery. But that was the first time he came to labor room, and sir was taking delivery. I was ready with my episiotomy scissors. Then he told, "Keep it down." Everybody might be knowing his slang of talking. Sir, episiotomy. Then he told, "In the episiotomy, no episiotomy." Then he took a delivery. There was a small tear. It was a 3.2 kg baby. And he told, don't put episiotomy unless it is indicated. Go and read. That was the first day I read about episiotomy, indications of episiotomy. I still remember Josa's delivery that day. It's like we used to say, Josa taking delivery is like, he's a movie director. It's like a song. That is how he take a delivery. And then only I also found that there is not much indication of episiotomy, and this 10%, maybe 90% still, but something to ponder. Thank you, madam, for that wonderful talk. Any comments from chairpersons?
It was a very nice presentation, Rani Madam. As she has rightly put, all the guidelines are favoring only the selective episiotomy. But like Sundari Madam has suggested, I also like to point that whether how far it is applicable to the Indian women, like, the compared to the Western population, our, pelvis structure, everything are different. So that is like she said, it's a controversy topic, but we need to find out how much it is possible for our Indian ladies, especially when you are dealing with some primi gravida at least. Then one more thing I would like to share is, as Rani Madam said, without most of the time, consent, we don't take the consent. That part I think we need to highlight. Verbal consent is a must. Not only verbal consent, it should be part of our antenatal education itself. They should be told much ahead about this, everything about episiotomy, all the how it is done, all the possible complications. This should be discussed beforehand itself so that they can have an idea when they go for delivery. I think that's it. Thank you.
Actually, we have a query from the attendees. Why IBS is a relative contraindication? I think it is a relative contraindication. Why? Rani Madam, any comments?
Actually, I searched into the cause of only selecting. That's final decision depends upon the person who is conducting the delivery. But if at all in an inflammatory bowel disease, you should actually avoid an episiotomy because there's so much inflammation involved, and that may be in case that episiotomy extends and leads to a tear, that also may involve the anal mucosa, which is already inflamed, and that was what I could find, that it should be as far as possible avoided in a case of IBD.
I think the inflammatory bowel disease like a Crohn's disease will be associated with already some perineal fistula and all. No? That may be the reason, perianal fistula more chance. So that may be one reason why it should place as a relative contraindication. Crohn's disease.
Thank you, madam. I think if no other comments, we'll move on to our next topic.
About the consent, can I say something?
Yes, madam.
Yeah,
Please.
ma'am.
About the consent, I think it's always better. This is a surgical procedure we are doing. So it's always better instead of oral, probably when we take a consent for the delivery and instrumental delivery, if we have to take, that time a consent one line, if we write the episiotomy, if necessary, will be performed. I think we can save ourselves. Suppose if the patient has some complication of episiotomy, sometime it can happen, then they have every chance to really take it up big, and then you have not told her that this can happen, this can happen. I'm not give. See, oral consent, yes, it's okay. During labor, we say that oral consent is adequate. But when we are taking, nowadays, we have to take consent when they come to a normal delivery also, no, in the labor room. In that consent, probably if we put episiotomy, in case if it is necessary, probably it'll be prudent for us to have the documentation that they have consented for episiotomy in case it is needed. That's what one thing I just wanted to tell.
Thank you, madam.
Thank you, madam, for that valid point.
Can I just add a word?
Sure, sure.
I may sound very much out of the box, but actually, while searching for about the short perineum as an indication, I came to found that it's like there are so many articles saying that the BPA of plastics have a lot to contribute to a short perineum. So maybe over time, we have to think of more of episiotomies in that situation, because BPA exposure in utero is so very common. The bisphenols in plastics. And it seems that the perineum is getting shorter over the generations.
Oh.
Maybe Indian women also.
Yes, it's adding to the reduced fertility and everything.
See, they say Asians. I read some paper about it. Episiotomy is indicated in Asians, they say, because short and very thick perineum probably our women have got. Paris women, when they are delivering, it's okay. But even then, I have seen sometime even Paris women, the tears, even when they give the full perineal support, because Asian women. See, unfortunately, we don't have our own statistics. I urge all the medical college people where they have a lot of cases, simple things like this, probably we can do it, studies, and we can have our own data. Unfortunately, Kala was telling, we don't have Indian statistics. At this era also, not having Indian statistics and depending on the other countries, especially Western countries, if you take, it's an entirely different. Even the collagen is different. Fibrous tissue is different. If you talk, perineal size is different. How can we compare them and they to us? If you try to do it, I mean, it is all, I'm sure all of us have experienced. When we don't give episiotomy, invariably we have tears. But you know how it is delivered in US. I think all of you must have experience with your children there or being relatives there. They allow them to happen, the perineal tears, even third-degree tears also happen there. So we have to rethink for ourselves, and high time we have our own statistics of episiotomies, and then what will happen if you don't give and then when we give. So studies, control studies, if we could go, we will come up with our own data. I think all youngsters, all the professors are here. I will urge to them to do these studies, and it will be very valid for us. Instead of just say, America says no episiotomy routine, we also say no episiotomy routine. Yes, that's good, because a lot of postpartum problems will be lessened for the woman. But is it feasible for all our women? Because what I observe is, as you said, pointed out, perineum is very short in our women. We have to think of it. Thank you.
Thank you, ma'am.
There's a question in the chat box saying, what is a short perineum? I don't know how far it is. Like in the literature, it says any perineum which is less than 30 millimeters is short. Anything between 30 and 60 is a normal perineum, and more than 60 millimeters is a long perineum, it says.
Sundari madam, we are definitely, we will plan for Indian statistics. We can plan some studies, madam.
Please, I'll be the happiest person. At least I'm honored by replying from your reply that you will study. Okay. Yes, ma, we have to do, and high time we have our own statistics, not going for other statistics and copying it. We have no dearth of patience, no. And all youngsters, you are all very energetic, very enthusiastic, very intelligent. If only put your mind, that's what I teach, because I'm in a medical education. I say, what is the level of research we are doing in India in OBGYN? Tell me. Why not? And the maximum patients we have in India in OBGYN. I mean, don't you think, all of you, because you have not been taught by us the orientation towards research. It's our mistake. We have not oriented you for research from the beginning when we were teaching you. Probably I take the blame for that. Thank you.
Thank you, madam. Point well taken, and I request Kunjumuddin sir, Subhash sir to look into it, and maybe Shaijas under research committee can flag off another research on this topic by KFOG, I believe. So thank you for giving the inputs. We'll move to the next talk on techniques of episiotomy. So we have next speaker. Kindly introduce the speaker.
Thank you, Rajesh. I'm more than happy to invite my close friend, Dr. Danya L, to this session. As she's my batchmate, I know her very well. She's a very good academician. As soon as this topic was when she was very enthusiastic, and I think she did all her homework. And she is ready to speak on about the techniques of episiotomy. And over to you, Dr. Danya.
Thank you, NC, for that wonderful introduction. And I thank all the KFOG members and the office bearers for giving me this opportunity. Okay, can I start sharing?
Yes, please.
Is it visible?
No, madam.
No. Start sharing option is not seen at present.
It is below a share screen.
Yeah. Okay. Okay, is it visible now?
Yes, please.
Yes.
So we'll start on the topic, that is the techniques and management of pain following an episiotomy. So as earlier speakers has told, the first description of episiotomy is found in 1742 in a fielding or a treatise of midwifery. It was published in 1742. So we have gone through the definition of episiotomy. It's a surgically planned incision on the perineum during the second stage of labor. It's also known as periotomy. All these things have been discussed earlier. And objectives we have seen. And now it is a selective rather than a routine procedure. And there is no it is no longer recommended to do a prophylactic episiotomy. So it is selective at present. So indications we have seen, the types. So I will go on to the types of episiotomy. The commonest one which we recommend at present is the mediolateral episiotomy. So mediolateral episiotomy occurs from the midpoint of the forehead and it is directed diagonally in a straight line around 60 degrees, either to the right or left. That right or left is determined by the operator's choice. Whether if it's a right-handed person, usually it is an RMLE. If it is left-handed person, it is LMLE. The next common thing is a median episiotomy. Actually, this is also of no use now. This starts from the center of the forehead and extends posteriorly along the midline for around 2.5 centimeter. Another type is a lateral episiotomy, and this is totally condemned because it can cause injury to the Bartholin's duct. The fourth type is a J shape. It begins at the center of the forehead and is directed posteriorly around 1.5 centimeter and then downwards and outwards along 5 or 7 o'clock position to avoid the anal sphincter. This will lead on to imperfect apposition. So this is also not done widely. So these are the two common episiotomies we prefer now. And the preferred one is a mediolateral episiotomy, that's on the right. And the left one is the midline episiotomy. And in this picture, we can see the J-shaped episiotomy also. Mediolateral, median, and J-shaped episiotomy. So what are the difference, or how will you compare the median with the mediolateral episiotomy? We'll go on with the merits first. With the median, actually the median is having more merits than a mediolateral episiotomy. Only one thing is the problem. That is, in a median episiotomy, the muscles are not cut. We cut directly into the perineal body. So the blood loss is least and the repair is easy. And the post-operative comfort is maximum here and the healing is superior. And wound disruption is rare in median episiotomy. And later, the dyspareunia is also rare. But in case of mediolateral episiotomy, the merits include a relative safety from the rectal involvement and extension is very rare. And if necessary, the incision can be extended laterally. The demerits of the median episiotomy is the extension if occurs, it may involve the rectum. So it is also not suitable for manipulative delivery or in abnormal presentation or position. As such, its use is very selective. The mediolateral episiotomy, the demerits include apposition of the tissues is not so good because a big chunk of tissue will be exposed. The blood loss will be more, as we know. Then the post-operative discomfort is also more. And there is relative increased incidence of wound dehiscence. And dyspareunia is comparatively more in case of mediolateral episiotomy. So at present, what we recommend is a mediolateral episiotomy. Because of the most important complication which can occur is the involvement of the anal sphincter. So that can occur with the median episiotomy. So at present, we prefer mediolateral episiotomy. So we'll go on to the technique of how we do, which is a most common obstetric procedure. And as we have seen earlier, WHO considers 10% rate of episiotomy as a good goal to pursue. But at present, Most of us are doing nearly 80 to 90% of episiotomies for our patients. So we will have to consider our factors also for deciding on this percentage. So first we'll go on to the timing of episiotomy. And the timing of episiotomy needs a good judgment. Like the problem is that if it is an early episiotomy, it will lead on to more blood loss. And if it is a late episiotomy, it fails to prevent the invisible laceration of the perineal body and it thereby fails to protect the pelvic floor. And the very purpose of episiotomy is thus defeated. What is the ideal time of giving an episiotomy? It is when 3 to 4 centimeters of the head is visible, bulging, thinned out perineum should be there. And that time when we give episiotomy, that is the best time. And when breech, in a case of breech, when the breech is climbing over perineum, and if we are applying a forceps, before or after the blades of forceps are placed, but before applying traction, that is the ideal time. So we'll go on to the steps of episiotomy. The first one is a consent. Actually, preliminaries including consent, it's a very important thing at present. We have to get a written consent. That's what I'm thinking. In our hospital, along with the consent for delivery, we are also taking a written consent for episiotomy. So this is I have written something as obstetric violence. This is a relatively new term where episiotomy is also considered as a type of obstetric violence where patients, actually this pregnancy is a physiological thing, we all know, and these patients are converted to patients without their consent. Like when we put an episiotomy, they are undergoing a surgical intervention and later there can be a lot of complications because of those things. So this is an upcoming thing known as obstetric violence and episiotomy comes under that. So after getting a consent, the perineum is thoroughly swabbed with an antiseptic. Usually it is a povidone iodine lotion and is draped properly. And the local anesthetic agent is the lignocaine. 1%, 10 ml is usually given. And the step 2 is how we give an incision. It is made at the height of contraction. We usually use an episiotomy scissors and we keep our index and middle finger inserted between the fetal scalp and perineum to protect the scalp of the baby. We can use knife or scissors. The most common thing we use is the episiotomy scissors. It is started at the midline of the posterior portion and is cut at a 60 degrees in case of mediolateral and directly downwards in case of median. Earlier we used to study like the degree was around 45 degree, but now it is, they say it has 60 degrees. So these are the muscles of the perineum and the pelvic floor, which we cut during the episiotomy. The structures cut during episiotomy include the posterior vaginal wall, then the superficial and deep transverse perineal muscles, bulbospongiasis and part of the levator ani, fascia covering these muscles, transverse perineal branches of pudendal vessels and nerves, and the subcutaneous tissue and the skin in that order. And now comes the third step. It is the repair of the episiotomy. Actually, the repair time is also very important because we have to wait for the expulsion of placenta. Once, if you don't wait for the expulsion of placenta, if you need an MROP, then it can disrupt the already started episiotomy repair. So always wait till the placenta is expelled. So what are the principles of repair? The principles of repair include a perfect hemostasis. It should obliterate all the dead spaces. Then there should be suture without tension. And always do a per vaginal and a per rectal examination to assess the full extent of trauma before starting to repair. This should not be forgotten. Always do a PV and PR examination to look for any extension of the episiotomy. So what is the sequence of repair? And in that, like usually we do what is a vaginal mucosa and submucosal tissues, perineal muscles, and then comes the skin and subcutaneous tissue. So now there is a question. Like when I learned, like in SAT, like in Medical College Trivandrum, what we used to do is a continuous non-locking suture for the mucosa, then an interrupted suture for the muscles, and a mattress suture for the skin. But now the recommendation like is actually a continuous lock suture for the mucosa, and along with that you can continue the same suture And a continuous suture is done on the muscles also. And even after the muscles, we can continue with the same suture to do a subcuticular stitch and close the skin. So with a single suture material, you can do all these things. And which are the suture material which is recommended at present? Like earlier, we used to do it with the catgut. Now it has become history. Catgut is no longer recommended. What we use at present is vicryl. Vicryl can be of two types. That is either regular vicryl, that is polyglactin, or a vicryl rapid, which is rapidly absorbed. The only difference between the vicryl rapid and the normal vicryl is that the absorption is more in vicryl rapid, so the need for removal of sutures are less. Some of the patients which we do the episiotomy with the regular polyglactin may come back for removal of sutures. So that is the only difference. So the European guidelines include primary suturing to be offered as a continuous suturing technique when repairing an uncomplicated episiotomy. So this is a picture where you can see the different layers of the episiotomy is being sutured. That is the primary thing. We have to inspect the episiotomy wound carefully, look for any extension, do a per-vaginal examination, do a per-rectal examination also to find out any extension into the anal sphincter. And then you start with the vaginal mucosa. Always start above the apex. You from the apex you come down. It's a continuous non-locking. That's what is shown here. And I also use a non-locking suture, continuous non-locking suture till the hymenal ring. You close it there. You can either come with the same suture, do a continuous suture over the muscle layer, and with that and also after completion of the muscle layer, you can go for either a mattress suture for the skin or a continuous subcuticular suture for the skin. So always identify the apex of the vaginal incision. This is very important. Sometimes you may miss that apex and it can lead on to heavy bleeding. So the close of vaginal mucosa to the hymenal ring with a continuous running lock suture. This is from the Thielen's Operative Gynecology 12th edition. It is so it's a continuous running lock suture of 2-0 absorbable suture. And close the fascia and muscles of the pelvic floor with 2-0 absorbable suture. And anatomic results are better with interrupted sutures. So that is the difference. This anatomic, whenever we do an interrupted suture, the anatomic healing will be better with the interrupted suture compared to a running suture. But continuous suture, the cause is that it will cause less pain, post-operative pain, and also during the procedure, the pain will be less and it will take lesser time. So the time for completion of the episiotomy repairing is less if we do a continuous suture. And in addition, more superficial layer of a suture may be required to optimally approximate the edges. And then close the perineal skin with 3-0 or 4-0 absorbed suture in a running subcuticular fashion. What I usually do is a mattress suture for the skin. And this is another picture of the same thing. Then comes the post-operative care. What you do after episiotomy? When you go for a rounds later, like after if the patient is okay, we have to advise regarding the dressing. Dress each time following urination or defecation to keep the area clean and dry. This is also important. And the dressing should be done by swabbing with cotton swabs soaked in a povidone iodine solution. And it should be followed by application of an antiseptic powder. That is better. And what about the pain management? There can be different types of pain management. It includes non-pharmacological methods and pharmacological methods. So first we will go on to the non-pharmacological methods. So the most important thing is that the patient has to should have a proper cleanliness of the perineal region. She should have always washed the area, keep it dry, and should change the pads frequently, and always wash your hands before and after changing the pads. And then another thing is the cold gel packs. This cold pack is also very helpful in alleviating the pain. The third one is the sitz bath, where we give a warm water for the sitz bath, where the patient can sit in a tub filled with warm water And this will actually, it's a warm, since it is a warm water, that will increase the blood supply, and it will alleviate the itching or any irritation there, and is good for the patient. And the healing is also better. Then comes the perineal care. Another thing is the Kegel's exercise. And one new thing I learned is the topical infrared therapy. Like usually we are not giving, but topical infrared therapy can be used. So we use infrared, that light can be applied. It is 230-volt light is used. It is kept around 45 to 50 centimeter away from the, and is applied for around 10 minutes. And this, the mechanism is that it will keep the area dry, and it will increase the blood supply to that area so that the healing will be faster. And also because of the heat, there will be local histamine release. This histamine also is supposed to improve the healing rate. So what are the pharmacological methods to alleviate the pain? So usually what we give is NSAID, and that is the right thing. Actually, all patients should be offered pharmacological methods also. What we commonly use is paracetamol, and ibuprofen is the first line. What I usually give either paracetamol or diclofenac. Then some mild opioids like codeine can be given. And if the patient is not getting better with this mild opioids, sometimes they need a stronger opioids like morphine or pethidine. Like we can also use a local anesthetic agents. Then if the patient was under epidural, it can be continued, and also prudental nerve block. So what is the ACOG recommendation for the pain management? Actually, if the in case of vaginal delivery, the first choice is always ibuprofen or paracetamol. And if there is continued pain, if the patient is breastfeeding, they can give a mild opioid analgesics can be tried. And if she is not responding, go for a higher potent opioid analgesics. These are the usual things there. ACOG recommendation. So after this, so we'll go to techniques how to prevent perineal trauma. This is another thing. Like like one thing is that is they can start this perineal massage. Actually, perineal massage should be started during the antenatal period around 34 to 35 weeks. They can start by themselves, and should be massaged around 2 to 3 times a week, 10 minutes per day. So that is also helpful to make the perineum more pliable for a delivery. And can be warm compress can be used during labor, and the hands on guarding of the perineum. That is another thing which is very important to have. You can support the perineum properly. Then they are saying about alternate positions. Alternate positions include a vertical sitting position and also lateral position. These positions are supposed to reduce the rate of perineum because of the available space is more. So the amount of trauma is less in case of vertical position and lateral position. The usual thing we do is a rigid maneuver, and we apply a moderate pressure over the chin, and that is a controlled extension of the head is tried with the modified rigid maneuver. So that comes to the conclusion of my presentation. I thank you, all of you, for your patient listening, and thank you.
Thank you, Madam. That was an excellent talk on covering almost all the aspects. Comments from Sundari Madam, Chairperson.
Yeah. Yeah, it's a very wonderful talk. You have brought out all the valid points very nicely, and then very explained also in detail about every aspect of it, that management of episiotomy, I mean, suturing of episiotomy, especially very valid points you have brought out, like look for the hemorrhage, look for the edges, and do it after placental removal. That's one thing I have seen even in my place, where the PGs and the junior staff will be in a hurry to start suturing off while the placenta. Of course, now with the management, 12th stage active management of labor, so we don't allow the placenta to be in, and then we have to remove it. And then one thing important is probably we have to see the edge of the vaginal tear is very, very important, as we said. And the technique of suturing, yes, been following this Ethicon. People have started training the interns for that. Actually, I don't know this part of the state. I mean, in our state, they periodically train the students in Chennai, I think. They do the continuous suturing, unlocking. Vaginal mucosa, I always tell the students and teach the postgraduates, don't take a very deep stitches in the vagina. That's one thing which can cause the dyspareunia for the patient. And when you are doing the hymenal ring at the hymen and the mucosa and hymenal junction, they have to be very, very careful. When they suture inadvertently, the perineum, it gets elevated. That's another place where the patient will have the dyspareunia. These things they have to take care of. I'm very particular about suturing the episiotomy. I stand there and make the PGs do that. And only the edges of the mucosa is enough. We don't take a chunk of mucosa and suture so that vaginal introitus, vaginal mucosa will become little narrow that they can have a dyspareunia. That's one thing. And giving it episiotomy, you said 60 degrees. When it is, one thing we have to remember, all the PGs have to remember is when it the overstretched perineum, we are giving at the crowning. Overstretched perineum, you give even at 40 degrees, it will come just to the midline of it. And every time I tell the PGs, once you do the episiotomy and suturing, you go back and see the patient after the suturing where you are episiotomy. Is it exactly mediolateral or it has come to the midline? Many a time overstretching perineum, our assessment of 60 degrees will not be correct and it almost comes to midline. Always I tell us, you go back, have the mental picture of it so that next time when it happens, you will know. And of course, it depends on the perineal length also when you are giving episiotomy. These are the precautions they have to take. Non-locking, continuous stitch. I have been doing it for many years. Of course, now I don't do much, but I have been doing it with a good success. Patients' pain is so less when you do with the subcuticular skin. Start with the mucosa, end it at the hymen, then go from inside, outside, come to the muzzle. And I always do the muzzle 2 layers so that the skin approximation, just subcutaneous, is enough. So the pain is much less for them. No interrupted sutures we do. That's what even Ethicon people teach us for the students, I think. And then the dressing, she said, the powder and ointment, is it necessary? I don't know whether, maybe our practices, it's different, but we don't usually use. We used to use iodine ointments, but it's metrogel ointment, iodine, but it's all given up now. Only the, as you said, sitch bath is enough, I think. And ask them to keep the perineum clean. Always they have to wash with the water when they go to the restrooms. I think that's it. And when they, one more point I just want to bring here is the way pain is not relieved by the usual analgesics. Please don't give diclofenac for the patients because a lot of diclofenac, you know what can happen. And our Indian, South Indian women, especially, I don't know about Kerala, Andhra and Karnataka, I know they don't drink water postpartum. When they don't drink water and we give diclofenac, you know, there can be some sort of urinary amount can come down. So I don't use diclofenac at all. Paracetamol is okay. Maybe ibuprofen if it is. When the pain is persisting in spite of our switch baths and then the light, whatever you give, plus the mild analgesics, we have to look into again the wound and then we have to examine whether there is any hematoma somewhere, especially deep hematomas and ischiorectal fossas we miss sometime. When they have a persistent pain, probably we have to think of that. Thank you. Anyway, thank you, Dr. Danya. It was a wonderful presentation.
Thank you, madam. Thank you so much.
Thank you, madam.
Madam, you have brought about very valid points, very pearls of wisdom you have given. That is if she's having persistent pain even after this analgesic, we have to think of hematoma. Don't keep on giving analgesics. That is very valid. And there are few questions that have come up in the chat box. Danya, one question is ironing off the perineum and giving rectal pressure recommended? That is one question that has been asked. And a few questions have been asked regarding antibiotic. Is antibiotic ointment, local ointment mandatory? That many are asking.
Actually, antibiotic ointment is not mandatory. You can keep the perineum clean.
Yes,
Cleanliness is enough. Actually, no recommendation like that.
Yes, Sundari Madam also has
Yes.
commented on that. That is keeping the perineum clean and dry,
Clean and dry.
and routine use of antibiotic ointment is not necessary. Then also regarding locking and non-locking of vaginal mucosa while suturing the episiotomy, we have been and an expert is also saying we have been practicing without locking, because locking will produce more ischemia and also more painful in the postpartum period. So, but it is in the guidelines. That may be why that you have included that.
Yeah, because guidelines are there, like in Tealand and all, they're telling it is locking. But now also, I also use only non-locking sutures. So for the PGs,
Madam also advocate non-locking sutures, isn't it, Madam? Sundari
Yes,
Madam?
for a long time I have been doing continuous suture non-locking.
Non-locking.
Nothing has happened for the patients. As you said, locking will cause a lot of pain, and a lot of vaginal mucosa is drawn into that locking stitches. Unless there is even if there is a bleed, I don't lock, but the bleeders, I just take a stitch, extra stitch, and then I do a continuous non-locking stitch only.
Okay. Okay, thank you, Madam. Then another question that has come up is, what is the technique of perineal massage?
It's called ironing of the perineum, with the fingers. They just stretch it like, what do you call it, ironing. So that's what they used to do. Actually, we were in a government hospital before Ramaya had its own hospital. I'm talking way back. And there, the midwives used to conduct the deliveries, and we used to be there as a Ramaya unit. I used to see when she is in the second stage of labor, they go on continuously doing the stretching of the ears, and beautiful, no tear would be there, believe me, and they could deliver these midwives. That is what has come back as a perineal stretching or the perineal massaging. Just with the fingers, you go on stretching at the perineum. Maybe a little bit of lubricant they can take, a jelly or an oil, and then they go on stretching it with the fingers. That is the perineal stretching.
Madam, that is done during conducting delivery, no?
That I used to see, but now they recommend it even during last weeks of pregnancy, maybe 1 or 2 weeks of pregnancy. So that, but what is the consequences of it, I don't know. Whether we'll get a pelvic floor problems because of stretching, we have no studies about it yet.
Okay. Previously, midwives used to apply castor oil in the perineum and massage it to the fingers.
Yeah.
Towards when in the labor. Madam, as Madam had rightly pointed out, when there is pain, it is actually, we have to look for hematomas. But I think switching on to codeine and morphine and all is going to add to the problems, because she's going to severe constipation.
Two things we have to think is, one is hematoma deep-seated, other is infection.
Or infections.
These two things we have to see before giving. There is no point, because usually episiotomy, well done, suturing and all, it will not have so much of pain. So whenever there's a persistent pain, we have to look into these things. I had ischiorectal fossa with the bleeding, deep hematomas we had. Then I had to open under anesthesia and then evacuate everything and resuture. So we have to think of persistent pain, these things.
Thank you, Madam. Thank you, Chairpersons. We'll move on to our next topic.
Okay.
We have the next speaker, none other than our dear Prasanna Madam, to talk on the complications and care of episiotomy.
Thank you, Dr. Reggie.
Sorry, Madam, please.
Yes. Prasanna Madam needs no introduction to us. She is a teacher of teachers, my own teacher. I'm very happy and proud to introduce Prasanna Madam, former head, actually she had worked at Trivandrum Medical College, Calicut Medical College, a professor and head, and now she is head of the department and senior consultant at Lifeline Hospital, Adur. And Madam is the author of postgraduate gynecology, and all of our students have that textbook with them, and they are referring that. And she had got WHO fellowship in way back in 1991, and she is the former president of KFOG. Madam, we are eager to hear from you, madam. And not only I knew that you had a surgery and recovering, and I really appreciate, madam, for your enthusiasm in teaching, and inviting you, madam, for this lecture.
Sadi.
Yes, madam.
Complications of episiotomy. Initially itself, I should talk about prevention of complications of episiotomy. One thing is you have to, the slide comes afterwards. Because my right hand is nestling, I was not able to make the slides. Sorry for that. Actually, complication, we were talking about so much about restrictive episiotomy. Restrictive episiotomy. Restrictive episiotomy means we have to prepare the patient mentally as well as physically. Mental preparation in the antenatal period as antenatal class. She should know how to push, and we have to take the consent for episiotomy at that time. And you should be telling everything about vaginal delivery. And she should be relaxed when you conduct the delivery. The obstetrician should be relaxed and the patient should be relaxed. In the preparation, she should be starting perineal massage. Perineal massage, even starting from 36 weeks onwards. She can massage with olive oil or even coconut oil, and with the thumb on one outside and the fingers on inside. You can massage with some oil so that the perineum will get relaxed. If the perineum is not relaxed, generally the tears will occur. We can make out whether she has a fungal infection, which should be routinely looked for after 36 weeks when she comes for antenatal checkup. There should not be fungal infection which predisposes her for more of lacerations. And after putting an episiotomy, then again another point in preventing episiotomy, we have to give, in the antenatal period, the massage should be with some oil. And in the second stage of labor, the massage can be with some water-soluble jelly like metrogyl jelly or lidocaine jelly. If you put jelly, then the need for episiotomy comes down. So that is why the WHO and the guidelines talk about restrictive episiotomy. The patient should be prepared so that he can restrict episiotomy. If you start from today onwards, you start telling the patient to massage the perineum with oil from 36 weeks onwards. And in the second stage, put some jelly in the perineum, water-soluble jelly in the perineum in the second stage. And wait for the head to crown. Don't hurry. Be relaxed. And the patient also should be relaxed. And if at all some sister is giving a fundal pressure, ask her to stop the fundal pressure. The fundal pressure produces all these problems of tear. So ask her not to give fundal pressure. You may be helping the patient, but that can cause more trauma to the perineum. If at all she is giving fundal pressure, don't give when the head crowns or head is being delivered. You can stop the fundal pressure. And she should be encouraged to bear down in between contractions. That's very, very important, so that you can avoid some amount of episiotomy. And it's not be a hands-off technique or a hands-on technique. Hands-off technique, you do nothing. Leave her to normal physiological labor. Hands-on technique, the resistance maneuver, where you prevent a premature extension of the head. That also has been proved that trauma to the perineum is more when you do resistance maneuver. It should be a hand poised technique where, if you think that the patient needs an enlargement of the outlet, then or it gets prematurely extended, then you flex the perineum, flex the head, and you relax the perineum with an episiotomy. And one thing which I wanted to tell when Dhanya was speaking, you give local, you put the local, introduce multiple puncture points to the needle. It should not be. The entire local should be given with a single puncture, and along the line of the episiotomy and withdraw the syringe and needle and push the entire local. And it should be given much before you conduct the delivery. As the patient is shifted to this for delivery, you swab the area and give the local, because the local takes time to act. You give the local and then immediately you put the episiotomy. It's very, very painful. So it takes time to act. So you have to give the local much early. Coming to complications of episiotomy after giving, there can be bleeding. And if the spurter bleeds profusely or even the vein bleeds profusely, can apply a small artery clamp and can be removed when the baby is being born. Otherwise, it can injure the baby. Perineal trauma can be trauma to the muscles, the first degree, second degree, and third degree, or fourth degree perineal lacerations, wound site edema, the hematomas. The infralevator hematoma is the common, the supralevator hematoma, or the superficial hematomas. Urethral injury is very rare. Paraurethral tears can occur. Paraurethral tear, from the paraurethral tear, she can bleed so profusely. I've seen somebody conducting delivery when I was conducting delivery. So she called me, "Madam, the patient is bleeding." I went and saw that she has bled some one-third of a big bucket from the paraurethral tear. You can put a swab, wherever she bleeds, you can put a swab and arrest the hemorrhage. She could have put a swab and arrested the hemorrhage. Or if at all she wants to suture it, you can suture it. There is no other structure laterally which can be injured. The urethra is in the midline and you can suture it. And if the episiotomy starts from the labia, you go starting from not at the midline but go laterally, you will be injuring the bulb of the vestibule and the bulb of the vestibule, which is a very, very vascular structure. So bleeding, hematoma, gaping, infection, every complication is more common if your episiotomy goes laterally. Don't go laterally. Start from the midline and then go 60 degree laterally. Coming to anal sphincter injury, I will come to the classification later. Supraelevator hematoma, retained swabs. So whenever there is a big laceration or multiple lacerations, the patient is not cooperative, the patient should be taken to the theater and should be sutured under anesthesia in good light with a good assistant. If you think that the assistant is not properly showing you, then you can actually tactfully avoid the assistant and ask somebody else to come and assist. It should be sutured properly. Otherwise, she can bleed so profusely. I remember one patient who bled profusely, and it was sutured by sutured in the theater by a senior person, and then morning the patient died. If there are multiple lacerations, it's bleeding profusely, then you can take the patient to the theater, open the abdomen, and ligate both Indian and iliac. Only Indian iliac supplies the vagina. So that way you can arrest. Sometimes, very rarely, there may be occasions to staunch the hemorrhage by ligating Indian iliac. Coming to the long-term complications, chronic infection, anorectal dysfunction, urinary incontinence, pelvic organ prolapse, and sexual dysfunction, because you have reduced the introitus. So that is a supraelevator hematoma. This is an infralevator hematoma below the infralevator hematoma usually bulges the perineum, and the supraelevator will not bulge the perineum. The patient complains of pain, always you do a vaginal examination. Always do a vaginal examination so that you can feel the hematoma bulging the vagina. It should be opened in the theater, and when you take deep bites, it can produce great bulge. When you arrest the hemorrhage by sutures, you can even include the ureter in the parametrium. So it's better to put a drain and suture the hematoma, I mean the blind area, and put a drain. So that will staunch the hemorrhage. The further procedure never has been need to be done. And infralevator also, same way you can evacuate the hematoma. Usually a bleeding vessel may not be identified, but you can arrest the hemorrhage and obliterate the area. So always when the patient complains of pain, as has been previously emphasized, don't give analgesics, don't go on giving analgesics. You do a vaginal examination, see everything is fine or not. It could be a hepatoma. And later on, she can have scar endometriosis, a rectovaginal fistula. This rectovaginal fistula or a rectoperineal fistula occurs because of the injury to the rectum. So that is why we always say, always do a rectal examination and a vaginal examination before you start suturing the episiotomy. The rectal examination will tell you whether the external anus sphincter has been injured or a rectum has been injured. I've seen a house injury in the rectum. Rectum is injured without injuring the rectum, the external anus sphincter or the anal outlet. Inside of the episiotomy, see, if you routinely do a rectal examination, you will find that the rectum is so close above the perineal body. It's so close. So when you take the bites, it should be only the vaginal mucosa or the vaginal skin, and should not be the deeper. So recently, I was called to see a patient, and I found that the person who sutured the vaginal wall has taken the suture to the rectum. Not only once, several bites through the rectum. So that can happen unless you identify the vaginal mucosa and suture. So that's another important point. The obstetric anal sphincter injury, anal sphincter, less than 50% is 3A, more than 50% is 3B, and 3C is internal sphincter injury. And when you suture the injury, all this you know. So that is the injury being sutured. You should have two small Alice forceps. Two small Alice forceps. See, this sphincter is completely torn, and this sphincter is reddish, and this sphincter is caught with Alice forceps. You put small Alice forceps. You should have small Alice forceps in the labor room. You put two Alice forceps and catch hold of the sphincter and suture the sphincter with ideally polydioxinone, PDS. 30 PDS is the ideal, because that is that produces less infection and disruption of the sphincter. And usually we suture with 20 Vicryl. Ideal is the polydioxinone, that is PDS. And here, the anal mucosa is not injured, only the sphincter is torn. And it is a 3C injury. And it should be sutured with 3 or 4 interrupted sutures. It should not be tight. And a fresh sphincter injury can be sutured with end-to-end anastomosis. And an old complete perineal tear can be sutured with a overlapping method. There should be, as already stressed, there should be proper exposure. Anal mucosa repair, if the 4th degree tear, anal mucosa should be repaired with 30 Vicryl. With a continuous suture is the recommendation by RCOG, but we usually repair with interrupted sutures. And I usually repair it with reinforcing lumbar sutures, so that it will be watertight.
Excuse me, madam. Slides വെക്കാഞ്ഞ തന്നെയാണോ madam?
Slides ഒക്കെ കളഞ്ഞു വെക്കാനൊന്നും എനിക്ക് പറ്റിയില്ല, കൈ വയ്യല്ലോ.
ജസ്റ്റ് ഒരു ഡൗട്ട് ചോദിച്ചാൽ മതി. ശരി, താങ്ക് യു.
ചോദിച്ചോളൂ, എന്തോ ഡൗട്ട്?
അല്ലല്ല, കുറെ പേര് സ്ലൈഡ് ഷെയർ ചെയ്യാൻ പറ്റിയെന്ന് ചോദിച്ചിരുന്നു.
അല്ല, അത് ഞാൻ എൻ്റെ യൂട്യൂബ് ചാനലിൽ ഒരു ഓൾഡ് കംപ്ലീറ്റ് പെരിനിയൽ ടയർ ഇട്ടിട്ടുണ്ട്. അത് പണ്ട് 2002 ഒരു ക്യാമറ കൊണ്ട് എടുത്തതാണ്. അത്ര ക്ലിയർ അല്ല, പക്ഷെ അത്ര ക്വാളിറ്റി ഇല്ല, പക്ഷെ ഇറ്റ്സ് വെരി ക്ലിയർ. ഇഫ് യു സീ ദാറ്റ് യു ക്യാൻ ഡു എ കംപ്ലീറ്റ് പെരിനിയൽ ടയർ റിപ്പയർ, ഓൾഡ് കംപ്ലീറ്റ് പെരിനിയൽ ടയർ റിപ്പയർ. ചാനലിലുണ്ടത്.
To the attendees, actually, madam is having some surgery for the shoulder. That's why the slides are not there.
Okay.
Please consider it as a chalk on board class.
There was a movie on recently sutured 4th degree tear that was there in the phone, but I tried to recover the movie. I couldn't. I tried today afternoon, but I couldn't retrieve it.
Please continue.
using a continuous non-locking switcher, interrupted switches can be used, but result is a larger quantity of foreign body. That's the guideline because of multiple nodes. We have been switching it interrupted switches. And I usually put a Lambert switcher, inverting the first layer of switches. And then comes the internal anus sphincter, which is lighter in shade, and it will be along the length of the anal canal, and that can also be switched with 3-0 vehicle. And then external anus sphincter, ideally with monofilament, polydioxanone. So I told you how to catch the end of the disrupted anal sphincter. If you routinely do a rectal examination, you can make out that the anal sphincter is injured, and it can be rolled with the thumb and finger if it is not injured. And another mistake is the internal, the tarsus perennial muscles can be mistaken for the sphincter because that also is reddish. And you can see the transverse perennial muscle actually decussates with the bulbospongiosus muscle. So that way you can exclude that it's not the sphincter. You can see the transverse perennial muscle decussating with the bulbospongiosus muscle. If it is external anus sphincter, it will not decussate with the external, the bulbospongiosus muscle. So it should be, sphincter repair should be an interrupted suture, and ideally should be polydioxanone. So that is the picture showing anal sphincter suturing, the end-to-end anastomosis. That is the overlap technique of suturing the external anus sphincter. In a fresh injury, you can do an end-to-end anastomosis, and in an old complete perennial tear repair, you can do an overlapping technique. Overlapping technique, you suture the one end to the one end to the other sphincter, and then as you have seen in the picture, 2 layers of switches will come. 2 layers of interrupted switches will come. And finally, it will be like this. That is the old complete perennial tear.
Madam, എന്തെങ്കിലും പിക്ചർ കാണിക്കുവാണോ മാഡം? സ്ലൈഡ് ഷോ ആക്കണോ? അല്ല സോറി, ഷെയർ സ്ക്രീൻ ഉണ്ട്.
ഷെയർ സ്ക്രീൻ ആണല്ലോ, കാണുന്നില്ലേ?
ഇല്ല
മാഡം, അതാണ് ഞാൻ ചോദിച്ചത് നേരത്തെ.
മാഡം സ്ലൈഡ് ഇല്ലെന്ന് പറഞ്ഞുകൊണ്ടാണ് നമ്മൾ എന്നാ വിചാരിച്ചത്.
സ്ലൈഡ് ഉണ്ട്, ഞാൻ ഷെയർ സ്ക്രീൻ ആണ് കാണിക്കുന്നത്. എല്ലാം പടം ഉണ്ടായിരുന്നു, പക്ഷെ എന്റെ ടെക്നിക്ക് ഫോണിൽ നിന്ന് എടുക്കാൻ പറ്റില്ല എന്നേ ഉള്ളൂ. നിങ്ങൾ കാണുന്നേ ഇല്ലേ? എന്റെ സംസാരം കേൾക്കുന്നുള്ളോ? ആഹാ,
ഇപ്പൊ മാഡം
കേൾക്കുന്ന പോലെ കേൾക്കുക.
നമ്മള് തുടക്കത്തിൽ മാഡം സ്ലൈഡ്സ് ഇല്ലെന്ന് പറഞ്ഞുകൊണ്ട് ആണ് നമ്മള് അങ്ങനെ മാഡം ക്ലാസ് എടുക്കുന്നെന്ന് വിചാരിച്ചത്.
ഒരു മിനിറ്റ്
മാഡം, പടം ദിസ് ഇസ് എന്ന് പറഞ്ഞിട്ട് റിപ്പയറിന്റെ പടം പറഞ്ഞപ്പോഴാണ് മനസ്സിലായത് മാഡം.
അതിനിപ്പോ എന്താ ചെയ്യേണ്ടത്? ഇതിപ്പോ എല്ലാം ഞാൻ കാണുന്നുണ്ട്.
ഷെയർ സ്ക്രീൻ
ഇവിടെ വന്നില്ല.
സൂമിന്റെ അടിയിലുണ്ടാവും മാഡം ഷെയർ സ്ക്രീൻ. സൂമിൽ പോണം.
ഇനി ജോയിൻ മീറ്റിംഗ് എന്നൊക്കെ പറഞ്ഞു വരുന്നു.
അല്ലല്ല മാഡം, ബാക്ക് അടിച്ചിട്ട് സൂമിൽ പോണം. ഞങ്ങളെ കാണുന്നുണ്ടോ മാഡം?
നിങ്ങളെ നേരത്തെ കാണുന്നുണ്ടായിരുന്നു, ഞാൻ കയറിയ പിന്നെ കാണുന്നില്ല.
മാഡം എക്സിറ്റ് ആയി തോന്നുന്നു.
ഇല്ലല്ല മാഡം എക്സിറ്റ് ആയിട്ട് മാഡത്തെ സംസാരിക്കാൻ നമുക്ക് കേൾക്കാം.
നമുക്ക് കേൾക്കാം.
Why it's there, no?
അല്ല മാഡം, സൂം എടുത്തിട്ട് അതില് നമ്മളൊക്കെ ഉള്ള ഭാഗത്തേക്ക് പോയാൽ മതി. മാഡം ലാപ്ടോപ്പിലല്ലേ മാഡം?
അതെ, ഇത്രയും നേരം കാണുന്നില്ല. അയ്യോ, കാണിക്കും. നീ ഒന്ന് സൂം എടുത്തിട്ട് മിനിമൈസ് ചെയ്യണമായിരുന്നു എനിക്ക്. അങ്ങനെയാ സാധാരണ ചെയ്യുന്നത്.
ഞാൻ അതാണ് ഇടയിൽ ചോദിച്ച മാഡത്തിന്റെ അടുത്ത് സ്ലൈഡ് ഉണ്ടായിരുന്നില്ല.
ഞാൻ വിചാരിച്ചു പടങ്ങളൊക്കെ എന്റേതല്ല, ഞാൻ സാധാരണ നെറ്റിൽ നിന്നും എടുത്ത് പ്രസന്റ് ചെയ്യാറേ ഇല്ല. ഇത് പക്ഷേ ഇങ്ങനൊരു സിറ്റുവേഷൻ ആയതുകൊണ്ട്
പ്രസന്റേഷൻ ഇവിടെ ഉണ്ട്.
പ്രസന്റേഷൻ എനിക്ക് കാണാം, അവർക്ക് കാണാൻ വയ്യ.
ഷെയർ സ്ക്രീൻ
സൂമിൽ പോയിട്ട് ഷെയർ സ്ക്രീൻ
ഷെയർ സ്ക്രീൻ മറ്റേ ചാറ്റിന്റെ റൈറ്റില്
കേട്ടോ.
ചാറ്റിന്റെ റൈറ്റിലായിട്ട് ഷെയർ സ്ക്രീൻ.
സൂമിന്റെ പേജ് എടുത്തോ?
സൂമിന്റെയാണ് ഈ സംസാരിക്കുന്നത്.
അല്ല മാഡം, പവർ പോയിന്റ് തുറന്നു വെക്കുമ്പോ സൂം ഒരു മൂലയിലോട്ട് പോകത്തില്ലേ? അപ്പൊ അത് ഒന്ന് വലുതാക്കി കഴിഞ്ഞതിന് ശേഷം
യൂഷ്വലി ഇങ്ങനെ സതി പ്രസന്റ് ചെയ്യുന്നത് ഞാൻ കാണുന്നു.
ഓ ശരി,
വെബിനാറിന് പോയി.
അതെ.
ഒരു കാര്യം ചെയ്യാം, സൂം അണയ്ക്കാം, എന്നിട്ട് പിന്നെ തോന്നുന്നു. ഒരു മിനിറ്റ്.
ആ താഴെ ഡോക്കിൽ ഉണ്ടാവും സൂമിന്റെ പിക്ചർ, അതിൽ ക്ലിക്ക് ചെയ്താൽ മതി.
എന്നെ ഹൈഡ് ചെയ്തതാണോ? നേരത്തെ എന്നെ കണ്ടായിരുന്നോ?
മാഡത്തിനെ
കാണാം.
ഇത്രയും കാലം പഠിപ്പിച്ചത് കേട്ടാ മതി.
കുഴപ്പമില്ല.
നേരത്തെ പറഞ്ഞ പോലെ ഒരു പാട്ട് പോലെ വേണം ഡെലിവറി കണ്ടക്ട് ചെയ്യാൻ. Should be like a music. And you should be relaxed and the patient should be relaxed. And that depends upon how you prepare the patient for delivery.
ഇപ്പൊ കാണുന്നുണ്ടോ?
ഇപ്പൊ കാണുന്നുണ്ട്.
Go over it quickly then.
ഞാൻ ഒന്നുകൂടെ ചുമ്മാ പോവാ.
കാണുന്നുണ്ടോ?
ഇപ്പൊ കാണാം. മസിൽസ്.
Okay, just do it quickly then.
ഇല്ല, അതൊന്നും കണ്ടില്ല ഒരു. ഇത് എന്റെ സ്പിങ്കർ ഇഞ്ചറി കാണിക്കും.
So you said all this. അത് കഴിഞ്ഞിട്ട്
ഇതൊക്കെ നേരത്തെ പറഞ്ഞതാണ്.
ഇതൊക്കെ പറഞ്ഞ മാഡം. ആ പിക്ചർ തൊട്ട്.
Picture. Yeah.
So you can see the supraelevator hematoma, which will not budge the perineum. So patient complains of pain, you have to do a vaginal examination because the hematoma will distend the vagina. Then only you can make out there is a hematoma. And you have to evacuate the hematoma. And while evacuating a supraelevator hematoma, you should be careful not to take deep bites because you can injure the ureter. And if it is it's ideal to put a drain with a glove or a something smaller, corrugated rubber drain, something like that. Otherwise, it can again form a hematoma. That's a supraelevator hematoma. Infraelevator drain is not necessary. You can evacuate and obliterate the. It can be in the very superficial aspect below the perineal, transverse perineal muscle, which bulges the perineum. That can be evacuated. I think this can be done in the labor room itself. Patient is not cooperative, then of course we may have to take the patient to theatre. And later on, she can go in for scar endometriosis, where the typical history will be paid during periods, and a rectovaginal fistula. This rectovaginal fistula, if she complains of some foul-smelling discharge, she should be examined under proper light because she may be having a rectovaginal fistula. One situation where I was called as a witness in the consumer court was a rectovaginal fistula, and the patient attended the hospital several times, and the gynecologist just did a superficial suture and sent her off. She recovered, and several months she had to suffer, and finally somebody repaired it properly. So if there is a rectovaginal fistula which is persisting, she needs a complete repair. Even if it's very small, it's not disappear. Sometimes, sometimes this rectovaginal fistula, it becomes smaller, and the symptoms become less and less within 1 month or 2 months. Then you can wait. We had such a patient delivered outside, came with rectovaginal fistula, rectoperineal fistula, and I said, we will wait. We waited, and after a few days, it became very small, And then after a month or 2 months, it disappeared. But later on, she has to be taken for a elective cesarean. She should not be kept for vaginal delivery later on. And this, if it persists, the patient should be, the repair should be properly done. Should be complete, make it a complete perineal tear and suture the anal mucosa, the internal sphincter, the external sphincter, and the perineum. So that is about rectovaginal fistula. Scar endometriosis, you have to ideally do a high definition ultrasound or an MRI and see how much it is and which level it is, and then you remove it. That is the first degree tear, second degree, the third degree, and the fourth degree. And I said about suturing the anal mucosa. The guideline is to suture with a continuous 3-0 vehicle so that the amount of suture material is less. But we usually suture with interrupted layers and then a lumbered suture, inverting the first layer of sutures. And the internal anal sphincter with ideally polydioxinone because it is monofilament. And it should be 3-0 polydioxinone, otherwise it will be thick. Or yeah, we usually suture with 2-0 vehicle. So that is the sphincter being caught with the Alice forceps. You should always have a small Alice forceps in the labor room. This sphincter should be caught with the Alice forceps, identified by rectal examination and also by the reddish nature of the external anal sphincter, and then catch with the Alice forceps and suture with ideally polydioxinone or vehicle, polylactin 910, and interrupted sutures. And the fresh tear can be sutured by end-to-end anastomosis, and then old complete perineal tear.
Hello?
Hello? An old complete perineal tear can be sutured by overlapping method. There should be proper exposure, anal mucosa repair, already said, internal anal sphincter and external sphincter. Internal anal sphincter can be identified by the lighter look, and it will be along the anal longitudinal external muscle of the anal canal. So that is the anal sphincter suturing, end-to-end, overlapping method.
Where are you? that board meeting.
Subhash Mallayada ശബ്ദമാണല്ലോ. That is from a textbook. It should have been a little more better suturing. That's what I felt when I saw this. Rectovaginal fistula. Well begun is half done, but in the context of surgery and in the litigation, it's time to rephrase it. Well begun is only well begun, and the meticulous completion makes it well done. That is what we must preach and teach. So this is the link to my channel where you can see the old complete perineal tear repair. Even though the video quality is poor, you can make out things. Okay, thank you.
Thank you, madam. In spite of the confusions, actually, madam, as Reggie said, it was like listening to you like in a ward class. So it was. It's only when you said, "See the picture," I understood that you are.
I am not knowing that you are not seeing the slides.
But it was very clear, madam, what you told. It's very clear. There is no problem. Thank you, madam, for the. Let's see the question answer box. Okay. That is, madam, one question is for skin, which is better, continuous subcuticular or interrupted subcuticular? That is one question.
Subcuticular is better, but we all put interrupted sutures. Interrupted sutures because subcuticular causes less pain, and interrupted sutures because if the patient has pain, especially at the lateral end of the episiotomy, we can cut that if it is interrupted.
Okay,
and there's a collection, you can cut that.
Okay.
So, if you are putting subcuticular, that is better.
Okay, madam. Thank you, madam. Then up to what extent mucosal repair is done? Up to hymenal ring or up to mucocutaneous junction? That is another question that has come.
Up to mucocutaneous junction.
Up to mucocutaneous junction. There is some madam, അത് നമ്മുടെ മ്യൂക്കോക്യൂട്ടനസ് വരുമ്പോൾ ഹൈമനൽ വരെ വന്ന് നിർത്തിയിട്ട് പിന്നെ ആക്ച്വലി മ്യൂക്കോക്യൂട്ടനസിന്റെ അവിടെ വരുമ്പോൾ നമ്മൾ വന്നാൽ അത് ഇവേർട്ട് ചെയ്ത് വരാനും അതിങ്ങനെ ഹാങ് ചെയ്ത് വരാനും ഒരു സാധ്യത ഇല്ലേ എന്നുള്ളതാണ്.
You're talking about anal mucosa injury or
No, vaginal mucosa, I think. Vaginal mucosa.
It's hymenal ring only.
Okay, hymenal ring only.
After suturing, it should be the original perineum. Your handiwork depends upon the perfectness of your handiwork makes everything. And this, if you are taking the patient to the theater and doing suturing in a high vaginal laceration, it's better to count the swab. So sometimes, you'll be using a lot of swabs to arrest the hemorrhage and see the tissues. Then one swab can be left behind. I had an occasion to retrieve a swab. Somebody sutured and I was called because it was difficult to suture. I went and sutured. I remember not having any left knee swab. And later on, patient came with something coming down, and we found that the end of the swab is there higher up in the vagina, near the posterior fundus. And we retrieved it and did a proctoscopy also, whether it has gone into the anal canal.
Okay, we have to be careful. These are the questions I think are related to the previous speaker. That is for episiotomy, shouldn't we take submucosa along with mucosa layer? Prasanna madam also can answer, madam. What is your opinion?
Submucosa and mucosa.
That is, why suturing episiotomy, vaginal mucosa and submucosa has to be taken?
Mucosa, submucosal layer. The whole vaginal thickness should be taken, but it should not be deeper. I told you very recently, I was called to see an episiotomy where they suspected that the suture went through the rectum. And I did a rectal examination only to find that the suture had gone through the rectal wall several times. And I completely undone the episiotomy and then sutured. I was scared whether she will go for a fistula because several times it had gone through the rectum. So if you identify the vaginal mucosa and suture, it will not happen. See, identifying the tissues is very important wherever you do surgery. See, even the small things should be very meticulously done. Even if it's a small thing like episiotomy, it can cause so many havocs to the patient. And you can face with so many litigations. I told you about the rectovaginal fistula patient with discharge complaining, and then several times she went to the doctor, and she was sent home suturing the superficial part. Even if it's very small, you have to do a proper repair. If it is decreasing and coming, disappearing, then of course, we had a patient with rectovaginal, rectoperineal fistula after episiotomy, but it disappeared. Gradually, she became symptomless and gradually it disappeared. So we don't do anything. And I told her next time you have to go for an abdominal delivery. And if it is not disappearing, you have to do a proper repair. Make it into a complete tear and then repair. If you are not doing a repair, we had a patient from Maldives where the repair was done in Indira Gandhi Memorial Institute or something there in Maldives. And when she came, we did an MRI and to find that she had several ramifications of the fistula. And we had a very tough time repairing that fistula. We injected some blue dye and then found out all these ramifications and then repaired the fistula. So it's not a simple thing. If the patient complains of any symptom, you have to properly examine the patient. If it is a foul-smelling discharge, it may be a fistula.
Then, madam, route of repair of supraelevator hematoma, abdominal or vaginal? That is
Vaginally only. Vaginally you can evacuate. Only thing is, don't go and obliterate the space taking a deeper bite. you can take a bite from the ureter. We have not seen like that, but we can guess that it can happen. So we have to obliterate the space, but you can don't take very deep bites. You can put a drain, one small drain you can keep.
Okay, madam. Rajesh, you were telling something?
No, that supraelevator hematoma, 2 or 3 questions. That's why it. And how to manage if sutures pass through rectum?
Remove it and repair. Undo the episiotomy and repair.
Okay, madam.
Okay, madam.
I think that was an excellent deliberation on the vast topic of complications of episiotomy. And once again, thank you, madam, for that wonderful talk and consenting to participate in this program, madam.
And one thing,
Sundar,
Rajesh, one
yeah,
thing,
madam.
if the episiotomy gives way and gape, you have to treat the infection and resuture the episiotomy. Otherwise, she'll have an introitus gaping and the husband will complain. So you have to undo the resuture the wound. Okay.
Understood, madam. Sundari, madam, any comments?
Yeah, madam has dealt very well. So I don't think I have anything to add more than that. Only thing it says is that we should not leave the episiotomy to the students. We deliver and then say, okay, you suture the episiotomy and go. I think we need to supervise them to do a proper episiotomy suturing so that they learn properly. That's what I think at the end we need to do this.
Thank you, madam. I think we'll move to the next topic. So we have been hearing a lot about all these basic things about the episiotomy. There are lot of confusions regarding what to do, what not to do. So now we want to know what the evidences says regarding the episiotomy. So for next talk, we have evidence-based practice in episiotomy, Dr. Sangeeta Madam. I invite the chairperson to introduce Madam.
It's my honor and proud privilege to invite Sangeeta Madam, who is a professor and HOD of the OBGYN Department of TD Medical College, Alleppey. She has continued a passion of teaching for the past 25 years with all the academics, and she has a well-driven passion towards the audits concerning reducing cesarean rates and maternal mortality. She's also an assessor of the confidential inquiry of maternal deaths. And of course, she doesn't require any introduction to this audience here because she's such a popular person and a teacher. She's also captain for the maternal near-miss surveillance and also a trainer of the ORP programs. She holds vivid interest in public health, and we have seen her conducting the AKCOG recently so well. It was organized. Thank you, madam. The screen is yours to share to us on the latest evidence-based practice.
Thank you, Ma. Rajesh, can I share my screen?
Yes, madam, please.
Yeah. Oh, for some reason, just a minute. Are you seeing my slides?
Not yet, madam.
Oh?
No, madam.
Okay. Now? Hello?
No, madam.
No. Oh God. Why is this happening? Rajesh, can you share my slides are with you?
Yeah, madam, I'll share.
There, I have no power here and it's just keep going on and off. So I'm kind of,
I'll share, madam.
yeah. Yeah, fine. Just make it the slideshow as well. I knew something like this would happen, and hence I sent it to you because I'm in Alapura and the current has been continuously going. It came only at 6:30. Anyway, so if you see me in the dark, I'm not in the dark ages. It's just that the current has gone. Thank you very much, Dr. Kunjumoideen and the team for having me here today. Very good evening to all the friends of KFOG and Sundari Madam, who's also a friend of KFOG. The topic that I was given is, am I audible?
Yes, madam.
Hello.
Yes, madam.
Okay. So the topic that I was given was what is the evidence-based approach to the episiotomy? So I thought I'd put in some questions as what would we need answers to? One is, should we do routine or should we do a selective episiotomy, which is superior? Does a restrictive use, that is a selective use, does it lead to more tears? And if so, are those tears more difficult to suture? And are we going to have more third and fourth degree tears? How do pain scores compare between selective versus routine? Is the blood loss more, more with a routine episiotomy? Is long-term morbidity in terms of incontinence and pelvic organ prolapse different amongst these two groups? How do I deliver a previous third or a fourth degree tear? And as many people have been arguing a little time ago, are Asian and Indian perineums more rigid and shorter? Next slide. Reggie, sorry to bother you.
Yes, no, madam.
So there are some indications which have absolutely no ambiguity. So these are definitely reasons why we will use an episiotomy. One is when we find the perineum is rigid, she's a preemie, very short, the head is banging on the perineum, not coming out, please use the episiotomy. Instrumental deliveries, even though there are proponents of the fact that you can use a selective episiotomy, many of us definitely use an episiotomy for the instrument. Non-cephalic deliveries, especially breech, internal podalic version, all those you need to have an episiotomy. Big babies, shoulder dystocia, face to pubis, preterm births, and in the African countries and probably even among some tribes in India, previous genital mutations also require an episiotomy. Next slide, please. So I think Danya had said about the WHO recommending a very good goal to pursue of 10% as an episiotomy rate, which actually was there in 2018. It came out in the WHO Reproductive Health Library. ACOG was of the same opinion as well. Next slide. And somebody had also mentioned that it's the unkindest cut of all. But let's look at some global trends. The first slide actually tells us about the developing countries. And China, though it has been reported as 44.9%, recent surveys have shown that Taiwan to have almost 100% episiotomy rate. India stands at 45. There are some studies saying 65. Indonesia and all, Iran, Malaysia, all the South Asian and Southeast Asian countries, you'll see the rates are above 50%, and some Thailand very close to 90. Cambodia is again 97%. In the US, the rates are down, but usually the episiotomies are, even though the whites are supposed to have better perineums, if you look at US statistics, the episiotomies are commoner in whites. The ones who have insurance have more episiotomies because they can stay a longer period of time. And the barriers to all this, whether you actually use an episiotomy or do not use an episiotomy, one could be the training policy that you have, how you have been trained, or the institutional policy, or basically in most of us, I think it's a fear that we'll really tear the perineum and the rectum very badly. Next slide. So in the developed world, the situation is really quite different. I was actually surprised, the Scandinavian countries, those women are very tall. They're very tall, they're broad, they're the Nordic tribes. So they have episiotomy rates of 4 and 10%, Denmark and Sweden.
UK has about 15, the US has about 12, and France has about 20. So if the topic that was given to me was, we need to know statistics. So let's know our numbers. So when we sit at departmental conference, we must understand that 3% of all vaginal births will have some form of tear, second degree, first degree, third degree, whatever. And 6.5, Tilakamurthy in 2014 said 6.1% of primaries and 1.7 multis will anyway tear. And very horrifying to note that these tears, what I'm talking about, these tears are not the first degree tears, but the third and the fourth degree. And even after it has been well repaired, 30% still had symptoms 1 year after birth. And perineal trauma in the US is the 4th largest reason where obstetric claims and settlements are concerned. So this is probably worrying all of us. But when large number of women, Argentina also has a high rate, when large number of women were studied, the restrictive group, that is in the group where you really didn't give the episiotomy unless it was, you're absolutely certain she needed it, there was a 2.4% or 2.4 fold. That is, these women had 2.4 times more anterior tears. When the anterior tears are spoken of, we are thinking of labial tear, also paraurethral, but not so as the posterior tears, which we are more worried about. So the restrictive group surprisingly had less posterior tears than if you were to use a routine episiotomy. That's a very strong point. And in the restrictive group, pain and healing complaints were obviously less because 30% of the women will get away without any tear or without any episiotomy at all. Next slide. So everybody has been quoting this Cochrane review. It actually shows no evidence. There's nothing more after that, but it really shows no evidence to support routine episiotomies in modern obstetrics. I'll just, over the next few slides, I'll just go through what that Cochrane really spoke about. They did a large number of surveys over a large number of women, and selective episiotomies resulted in 30% fewer women experiencing severe perineal or vaginal trauma. So 30% in the restrictive group really fared very well without absolutely anything at all. We do not really know if there is a difference in the amounts of blood lost at these two groups, whether it is restrictive or routine. But there was a statistic that stated 27 ml less in the selective epis, which really does not make any statistical significance. Both the selective and the routine showed little or no effect in APGAR scores. You know, when we were students, we believed that the head was banging against the perineum and that will cause the baby not to cry at birth, lower APGAR scores. But really, it did not show any effect at all, and that evidence is caught of moderate certainty and quite good. So really doesn't make any difference at all. Next slide. There was also little or no difference in perineal infections between whether you did selective or whether you did routine. We actually do not know of a difference in moderate or severe pain. The very well-worded sentence, because nobody is able to come to a conclusion whether there was a mild pain is definitely not there in the restrictive group. But in moderate or severe pain, we don't know the difference. There's also little or no difference in dyspareunia after many months, especially if it's a well-sutured episiotomy, as Prasanna Madam was so beautifully teaching. If the ends are apposed correctly, your perineum is how it was earlier, not one side up and one side down. It's highly unlikely that there will be dyspareunia. And there's little or no difference in long-term urinary incontinence. Next slide. Long-term pelvic organ prolapse also, there was no difference. So that means saying that by pushing and straining against the perineum and the perineum becoming weak with stretching, we got a lot more prolapses is really not true. Now comes to the part where we could do something. Warm compression during the second stage of labor reduces OSS risk. So if you have a nurse or a midwife, or in our days now, respectful maternity care and birthing in, where there is a companion with her, using a warm towel, not hot, warm towel just on the perineum during the second stage of labor reduces the OSS risk. And if there was an OSS in the, suppose she had an obstetric anal sphincter injury in the previous pregnancy, they need to be counseled and they can opt for a vaginal delivery. Prophylactic episiotomy, as per what they say, need not be required as and when the situation demands. However, if she is either symptomatic, so let's say after the first delivery, she is a little incontinent, or she has flatal incontinence, or you've done an endoanal ultrasound or an endoanal manometry and she has an abnormal finding, an elective cesarean section may be offered. Now, at this stage, it must be clearly understood that a rectovaginal fistula is a plastic repair on the perineum that requires an elective cesarean, not a previous tear. There was a lot of debate about the cutting angle of 45 to 60 degrees is important. We must understand that if, there are times when we use an instrument, especially when you're using an instrument, when the head is really not distending the perineum. So in those instances, the stretching distance is not much. It's an unstretched perineum. So the difference of 45 to 60 will make a difference when you're using an unstretched or a stretched perineum. On a stretched perineum, if you take 45 degrees, once it becomes unstretched, it will be about 20 and you will hit the sphincter. So go mediolaterally, but 60 degrees is an important measure when you want to prevent an obstetric anal sphincter injury. Though not studied, a perineal massage from 35 weeks with a lubricant is recommended. Now, here there are no studies that tell you, but few studies which have smaller number of patients. And here they really recommend the woman can't do it alone. You can't lie down and do it on your own because you have a big abdomen blocking your path to your vagina. So somebody has to help you out with it. And preferably in the dorsal position on the bed. Almond oil, olive oil, whatever oil, or a lubricant, gently between the posterior rim of the foreshe, just go up and down and do a perineal massage. In this, at this juncture, I'd like to say that now that we are seeing so many migrant laborers, I'm beginning to think that the average Malayali, or rather in Kerala, perineums are tight and rigid because most of them are under bed rest. They don't do any work. Whereas these poor migrant laborers are sitting down, actually squatting and making chapatis and doing things so that they come, deliver and go before you can say Ripko and Winkle. So I think perineal massage definitely, but also sitting, squatting, moving around will probably help. As Madam had so beautifully said, deliver the head between contractions or slow down the head at crowning. Don't let the head just pop out because that could cause an anal sphincter injury, and that is a very high quality evidence saying that if you do a slow delivery of the head, use the Ridgen maneuver, flex the head, bring it out between contraction in a slow fashion, you could probably prevent an anal sphincter injury. Can I have the next slide? Yeah. So mediolateral episiotomies, as all of us had agreed earlier, much better. We don't do anything else. Midline does predispose to obstetric anal sphincter injuries. When you use a midline, you have a 19% risk of developing a sphincter injury, whereas only 0.5 to 2% overall if you were to do a midline. And obstetric anal sphincters are commoner with forceps than with vacuum, and it obviously depends on your training to decide which instrument you're going to use. But if you're fairly comfortable with both, then on a personal basis, I would see, look at the distance of the foreshe from the anterior anal verge and see the distance of that perineum. If it's a very short perineum, then use the vacuum. If you're fairly comfortable and you have a good episiotomy, do the forceps. This last bit of it, sorry, just go back to that slide because I spent about 1 day looking for this, because we always talk about perineums that are tighter and more rigid and shorter in Asian women and in Indian women as such. But I was finding it very difficult to get data on whether we are really more rigid or not. Eventually, I got a large study, very well done, in Monash in Australia, and they actually looked at 3 sets of people. They looked at the native Australians and the New Zealanders. They also looked at South Asian, that is all of us, Indians, Pakistanis, Bangladeshis, Afghanis, and they all, the third group was the Southeast Asians. That's the Malays, the Singaporeans, the Japanese, and the Cambodians and all of them. And they said the anal sphincter injuries was 2 to 4-fold higher in Asians than in the Australians or the New Zealanders. They did confound for all the other most of the other variables, but they also believed that we were smaller built and therefore these kind of tears are more common. So Asian perineums are probably not as supple and we don't have such long perineal bodies that the Westerners have. Next slide. When you looked at perineal outcomes, which is the thing that we should be looking for, we said restrictive group had only 10.2% bad perineal outcomes, that is tears and all that. With the routine use, 51% of them had something that where extension took place. So 33.9% in the restrictive group had actually no tears at all. So if you were to follow a restrictive policy, about 35% of your women will have go home on the very next day with absolutely no problem. And third and fourth degrees were rare and they really did not differ between the two groups. So if anyone is actually thinking of studying restrictive versus selective, don't worry, you won't have more third and fourth degree tears. Next slide. So I said the anterior and the labial tears that required suturing in primaries and multis. In nullies, there was 74%. That's the primary who were delivering. There was 74% in the restrictive group and 89% in the routine use group. So even if you did the episiotomy, you had an incidence of needing to suture the anterior, and anterior tears are not so difficult to suture. In multiparas, 66% in the restrictive and 69% in the routine use group, which really did not amount to much statistical significance. So to summarize, I'd say massaging the perineum, warm compresses in labor can be tried and very applicable for us to do. Learn and teach good perineal support, not to take the hand off when the shoulders are coming. If an episiotomy is required, get the cutting angle right, because the cutting angle will determine whether you're going to tear the anus and the rectum or the sphincters. We could at least try avoiding episiotomies in multis. And then once we're a little bit more comfortable, then you start trying the restrictive use principle. And most importantly, Madam had said, before you start suturing your episiotomy, put your finger in the rectum, see if you buttonhole the rectum, and learn to diagnose a tear and suture it correctly. Thank you so much. I think that will be it.
Thank you, madam. That was a wonderful session on evidence in episiotomy. When thinking about the topic, we had no confusion regarding whom to give this topic. No better person than madam for getting the recent evidences in any topic. So thank you, madam, once again.
Thank you, Rajesh.
Over to chairpersons, Sundari madam.
As usual, Sangeeta, it is wonderful.
Thank you so much, madam.
You have really cleared all the doubts, I think. It's very nice.
Thank you, madam. Any comments from chairpersons? Actually, we have no new questions.
Ira, there is a recent evidence on massaging the perineum. AJOG
Yes.
March 2022. There is a severe, there is a reduction in the severe perineal trauma to the extent of 51%, and there is a 44% reduction of rate of episiotomy. That is a meta-analysis of 3,374 women.
I must have
all
missed
of
that.
you,
Thank
all
you.
of the juniors who are starting obstetrics.
Yeah,
obstetrics
to massage.
is an art. It's an art.
So, yes. So massaging the perineum is in 2 phases, 35 weeks and in second stage.
With olive oil or coconut oil, and in labor with some water-soluble jelly like lignocaine or metrogel jelly, and you iron the perineum. Previously, all these, the eyes, they used to iron the perineum and patients used to deliver. And we avoided all the eyes and produced all these perineal lacerations. It's what
Absolutely correct, madam.
So that is a good take-home message, at least from this session. Everybody should be remembering now about the perineal massage, at least.
Yes.
You can practice doing perineal massage. See, I used to teach patients to squat See, Sangeeta was
yes.
telling about the migrant patients squatting and sitting chapatis. They used to come and deliver. See, I used to tell the husband or the mother to hold the hands of the husband or mother, take deep breath in, squat, and breathe out and get up. So this they can practice, and the butterfly movement of the legs also.
Yes.
That will relax the perineum. These
Yes.
women, nowadays they don't move at all. They take complete
True,
bed rest,
true.
and
True.
they will not care the perineum. They won't have coitus also. So everything will be so rigid, and they have to relax. When they relax, the perineal muscles, the levator, everything will relax, and
Yes.
this ironing will definitely help. You start practicing this perineal massage, antenatal period and in labor. It will definitely help. And hands off and hands on, hands poised. So if you think that the anterior perineum is getting stretched, then you do the resistance maneuver, not routinely. When you feel that the anterior perineum is getting stretched, then you give resistance maneuver. Otherwise, don't do anything. It will automatically come. That's what I feel. The patient should be relaxed. The obstetrician also should be relaxed. And you should have to conduct the delivery as a music.
Actually, there is a question in chat box. On a multigravida, is it better to do episiotomy on the old scar tissue or a new episiotomy lateral to the old scar?
You should not
I
produce
think,
scars.
yeah.
Answer.
I think, see, very often the previous episiotomy is not even, it's difficult to make out. But some women definitely have scarring, but you can't give them, like Madam said, two trail track incisions on two sides. So follow your 60-degree principle and give the episiotomy. Even if it's over the previous one, it's fine.
Okay, madam, thank you. I think we'll move on to our last talk. Before going to the talk, actually during our inaugural function, we missed two people. I think Veena Kumari madam has joined few minutes time back. Madam, can you unmute and
Madam, may I invite Dr. Veena Kumari madam to please give a felicitations, madam? Veena madam?
Hello, can you hear me?
Yes, madam.
Yes, ma'am. Yes, ma'am.
Okay, thank you, Subhash. And no, I don't have any video because my computer is out of order partially. My camera is not working. Rajesh, Subhash, and all the organizers, thank you so much for such a wonderful webinar. I'm very happy that my society has got the maximum number of participants in this webinar. Satya as a chairperson, and Rani, Deepa, and who else? Yes, total 3 people are there from Kottayam Society. Thank you so much and all the best. Thank you.
Thank you
very
madam.
much, ma'am. Thank you very much, ma'am.
So we'll go to our last topic. Actually, it's video presentation, and we have Dr. Deepa. I request chairperson to introduce the speaker.
Yes, thank you, Rajesh. I am very happy to introduce my own friend, Dr. Deepa Matthews. She's my colleague. She is Professor Cap in our Department of OBG at Government Medical College, Kottayam. She has served our society as Joint Secretary a couple of years back, and she was Vice Captain of MDNMSR of Kottayam District. And she has to really took pains like in taking that video and editing and very eager to see that. Over to you, Deepa.
Thank you, Sadi, for that. Thank you, Sadi, for that introduction. And
share screen cheyam.
1 minute.
Yeah. താഴെ ഷെയർ സ്ക്രീൻ
അല്ല ഞാൻ ഷെയർ സ്ക്രീൻ വന്നു അതല്ല ഞാൻ ഇതൊന്നും എടുത്തോട്ടെ ഡെസ്ക്ടോപ്പ് റൈറ്റ് ഷോ
കാണിക്കുന്നുണ്ടോ?
അല്ല സ്ലൈഡ് ഷോയിലോട്ട് കൊണ്ടാക്കി.
അല്ല നമ്മള് we are not seeing your screen.
You're not seeing?
No.
No?
Not seeing. Share screen. Rajesh, can you please instruct how to?
Madam, ഷെയർ സ്ക്രീൻ കൊടുത്തിട്ട് ആ വരുന്ന ഓപ്പൺ ആവുന്നതിന്റെ അകത്ത് ആ പ്രസന്റേഷൻ സെലക്ട് ചെയ്യണം.
ഇപ്പൊ ആയില്ലേ? ഓക്കെ ഇവിടെ നിർത്തോട്ടെ. സ്ലൈഡ് Is it visible now?
Yes, slideshow again.
Slideshow ആക്കോ madam.
അയ്യോ വന്നോ അത്?
ഇല്ല, അത് പോവുക ചെയ്തത്.
ആണോ? ഷെയർ സ്ക്രീൻ
വന്നില്ലേ?
ഇപ്പൊ
വരുന്നതേ ഉള്ളൂ. വന്നത് പോയി, ഇനിയിപ്പൊ വന്നില്ല. പിന്നെ
മേഡം ഷെയർ സ്ക്രീൻ കൊടുത്തിട്ട് ഓപ്പൺ ആവുന്ന ഒരു വിൻഡോ അല്ലേ, അതിന്റെ അകത്ത് അത് സെലക്ട് ചെയ്യണം. തിരിച്ചു പോകരുത് പവർ പോയിന്റിലേക്ക്.
ഒരു മിനിറ്റ്.
എന്തായി?
വന്നോല്ലോ? ഇല്ല. ഷെയർ സ്ക്രീൻ
മേഡം ഷെയർ സ്ക്രീൻ കൊടുക്കുമ്പോ ഒരു വിൻഡോ ഓപ്പൺ ആവുന്നില്ലേ? അതിന്റെ അകത്ത് പവർ പോയിന്റ് സെലക്ട് ചെയ്യുക. സെലക്ട് ചെയ്തതിന് ശേഷം അടിയിൽ ഷെയർ എന്നൊരു ഓപ്ഷൻ വരും. അതെ
വരുന്നുണ്ട്.
വന്നല്ലോ.
വന്നു.
സ്ലൈഡ്
ഷോ അത്
റൈറ്റ് സൈഡ് താഴെ ജസ്റ്റ് റൈറ്റ് സൈഡ് താഴെ.
ഓക്കേ.
നെക്സ്റ്റ്. Yes.
Okay.
Done.
Yes.
So thank you, Sadi, for that detailed introduction, and thank you, KFOG Academic Committee, for giving me this opportunity. Actually, when Rajesh gave me the options of history of episiotomy and video, I was like, how do I take the history? And I agreed to the video. After agreeing to the video, I was like, why did I agree? Because taking a video, editing, all those things, it's all difficult, right? Anyway, I have with my friend Sadi's and my SR and Jaya's help, I've managed to get the video. So now, anyway, all the points have been covered in by the previous speakers. And now, okay, I'll just go to the video straight. So for the episiotomy, we have already mentioned that it is most commonly performed episiotomy is right mediolateral. Medial episiotomy is not advisable these days. And it is the RMLE, right mediolateral episiotomy, which is widely performed. Okay, so in consent we have talked about, we should have an informed consent, preferably a written consent. Maybe it is in the general consent for the delivery, somehow it has to be there. Antibiotic prophylaxis before episiotomy, that depends upon the institutional policy. In our institution, within 6 months of membrane rupture, if we anticipate delivery, we usually don't give antibiotics. Or else we can give a single dose perioperative prophylaxis also. And then coming to the position of delivery, I conveniently choose not to mention the other other positions than dorsal position or lithotomy. Anyway, the repair of episiotomy, it has to be done in the dorsal position or lithotomy position under good light. Coming to the these are the instruments we need for episiotomy. So under for anesthesia, if there is not adequate epidural analgesia for the suture episiotomy and repair, we can give local anesthesia, and local anesthesia recommended, as we mentioned already, it is 1% lignocaine. Then episiotomy cutting scissors, a tailed tampon. Tailed tampon is to be introduced into the vagina before suturing the episiotomy. Tail tampon because the tail helps us to retrieve it completely. Prasanna Madam had mentioned about the forgotten swabs and all. It has happened for us also. So cotton balls coming out of the vagina. So in order, cotton balls, even if we try to remove, it may not be completely removed. So tail tampon is always safe for that. Local anesthesia, syringe and needle. Suture, I have kept a catgut. Even though we mentioned that it is historical, we still get to do episiotomy with catgut. So it is there. Needle holder, thumb forceps, suture cutting scissors, a mop or wet mop to give wet mop to press the episiotomy if it is bleeding. Okay. Coming to the steps of episiotomy. Injection of local anesthetic. As Prasanna Madam said, it has to be injected in the line of episiotomy, proposed episiotomy. We should not put multiple pricks. It should be in the line of episiotomy or at the most lateral and medial to the episiotomy in a one line you can give. Okay, so that is the local anesthetic being given. Timing of local anesthesia, this I have shown when the head is crowning almost. And this is the procedure per se, cutting of episiotomy. It has to be done in a single cut. Here you can see it is like we have done 2 times cut. So it is, again, I would like to repeat, it is almost 60 degrees after crowning towards the ischial tuberosity. And that is the, that is the swab being kept. Okay. So after the delivery of the baby, we have to examine the upper vagina and cervix, which can be done before the placental separation if we retract the posterior vaginal wall using the both the hands. In that case, we can visualize that time we can visualize if there's any major tear in the upper vagina or cervix, usually which won't be there. And after the delivery of the placenta, we have to examine the vagina and also rectal examination. So here, this is the rectal examination to rule out the anal sphincter injury, external anal sphincter injury by the pill rolling method. The index finger is in the anal canal and the thumb is on the episiotomy. That we have to change the glove after the examination. Okay, so I've given an animation. Episiotomy suture, as already mentioned, is done in 3 layers. Innermost layer is the mucosal layer. So if timing of episiotomy, as we said, as we have heard already, too early an episiotomy will lead to increased bleeding. And that can be controlled by applying a warm, like wet towel, keeping the episiotomy pressed over the wet towel, over the episiotomy with a wet towel and giving pressure. That will decrease the bleeding. Okay. And coming to the repair after examination, mucosal repair. So episiotomy, as we know now, it is like a second degree perineal tear. So this in this video, it is a second degree perineal tear in the midline. Okay. So the mucosa, muscles, the bulbous spongiosum and transverse perineum are being cut in episiotomy. This, even though this is a tear. So in the mannequin, it will be like this. The suture at the apex should be at least 5 millimeters above the apex. This is to prevent the small vessels retracting. Okay. Sometimes the vessels retract at the apex. If we don't go this high, it will retract and it can cause an episiotomy hematoma later. So the initial suture is placed above the apex, at least 5 millimeters. And here you can see the white layer and the red layer, that is a submucosa. Mucosa and submucosa are taken together. Again, in the submucosal layer, there are vessels which can retract. Sometimes, most often when we explore an episiotomy hematoma, we don't see an isolated vessel. It will be a diffuse ooze. So this will take care of that. We have to take care of the submucosa as well. But the sutures should not be too wide, because widely taken bites will narrow the vagina and cause dyspareunia, as already mentioned. So the sutures should include mucosa and submucosa. And as Prasanna Madam said, we have to identify the mucosa and identify the tissues correctly in order to avoid inadvertent suture placement into the rectum. Especially when the apex goes towards the midline. No? When it is proper right mediolateral episiotomy, there is less chance of the rectum being involved in our sutures. But if it is going medially, midline rectum will be more closer. So we have to be very careful in taking the mucosal bite. So after suturing the mucosa, the outer limit is hymenal ring, like level of the hymenal remnants. Okay, so till there we have to come with a continuous suture. So I have been taking a continuous suture here. It is a continuous non-locking. You can see the episiotomy edges are ragged. That is because we had given 2 or 3 cuts. It was not a single clean cut. And the mucosal edges are slightly ragged. There is increased bleeding from the mucosal edge. And the suture material shown is a 320 regular vicryl. A swab can be used to press the edges and make it clear. Tissue identification is very important before putting the sutures. And the medial end in an RML, right, mediolateral episiotomy, the medial end may be slightly longer than the lateral end. In that case, we have to take wider bites. Look, the sutures should be more apart in the medial side than the lateral side. Then only the approximation will be proper. In the midline episiotomy or midline tear, this is not the case. It is symmetrical, more symmetrical. So it can be equidistant. Hope I am clear. Excess bleeding from the edges can be controlled by pressure. Or if there is particular bleeder at the mucosa, there we can put a locking suture, or as Sundari Madam mentioned, they can put an additional suture there to control the bleeding from that point. Here again, you can see there's an increased bleeding from the lateral end, which is controlled by the pressure, by the assistant. After coming to the hymenal ring, we can either end it there or can go for a continuous suturing of the muscle layer. I have ended it there at the hymenal ring area. One advantage of ending it there is, as Madam mentioned before, if it is in single layer, entire mucosa, muscle and skin, then we can, if they need to undo it, it is difficult. So here you can see a continuous layer, a continuous suture after the mucosa going to the submucosa, muscle. Muscle layer, when we suture, what is important is the bulbocavernosus, if we are not careful to approximate, if we don't take particular care to approximate the bulbocavernosus ends, the introitus can sag. So it is very important to take that muscle bulbocavernosus ends separately and cautiously just below the mucosa. Muscle layer can be sutured in single or double layer depending upon the thickness of the perineum. So that is the muscle layer being taken care of, bulbocavernosus being approximated. There's a name for the suture, that is the crown suture. Crown suture it is called, the approximation of the bulbocavernosus ended there. Hence, what will happen if we can come with this thing, mucosal suture, if we take it to the mucocutaneous junction? Often, when we take the suture to the mucocutaneous junction, the mucosa suture, especially for the beginners, interns and all, we tend to overlook this bulbocavernosus approximation. And we may suture the transverse perineum alone. So then the sagging of the introitus can happen later. So the bulbocavernosus has to be approximated and rest of the muscle layer can be taken care of in single or double layers. Double layers will have more approximation. But thinned out perineum and all, sometimes single layer may be enough. And as we already heard, intermittent sutures in the muscle can lead to more pain. Also more suture will be there, knots will be there. So if we are using braided suture, especially regular vehicle and all, there is increased chance of, theoretically at least, there is increased chance of infection because of the braided suture material and loading of organisms. So after suturing the muscle layer, next will be the skin. Skin again, here you can see the continuation of the muscle layer is going to the skin. And skin is done in a subcuticular fashion. Advantages already mentioned, less pain, more approximation, and less suture material. But one disadvantage is in case there is infection, if we cut, the entire thing will be gone. So that is the disadvantage of a continuous suture. The knot can be buried or it can be outside. if we are putting interrupted sutures for the skin, we have to be careful that it is not too tight. Episiotomy, one important point of suturing episiotomy is no suture should be too tight. It's just approximation. Perineum is a very vascular organ and it just needs approximation.
Video got paused.
Hello, the video. 1 minute, please. Running out of charge. Okay. So skin sutures also should not be too tight. And if we are putting interrupted sutures, the knots, it is better. The knots come away from the anal edge. Okay, so it is better it is on the lateral edge. And also we should not leave the suture ends long. Because perineum is an area where, especially after defecation and all, it can get contaminated. So long suture ends will acquire more organisms from the perineum if we are not careful. So it is always better to leave the suture threads short if we are putting interrupted sutures. Perineal care is mentioned already. After suturing the episiotomy, again we have to do a rectal examination. We have to make sure that before rectal examination, we have to remove the tampon. I usually remove the tampon at the end of mucosal suture. That is because if there is any excess bleeding from the uterine cavity, that can be handled before the suturing of the muscle and skin. So after mucosal suture, I usually take out the tampon. So after episiotomy repair, we have to make sure the tampon is out. There is no cotton or swabs left in the vagina, and we have to do a rectal examination and make sure that there is no sutures in the rectum. Initially, we have done a vaginal rectal examination to make sure that anal sphincter is not involved. So after all these things, we can clean the area, and proper documentation is again important. Even doing PR, in the notes we can write PR done. All those things have to be mentioned. Okay, coming to the, so that is regarding the documentation. Perineal care is as important as the suturing. So immediately after repair of the episiotomy, we can apply ice packs to reduce the swelling and pain. 10 to 15 minutes you can apply, but that ice packs should not be directly applied. It can be covered in a mop or gauze and applied. Warm sitz bath starting from second day if she has excess pain. Oral analgesics already mentioned. And more important, I would say, is visualizing or examining the episiotomy. Even if she does not complain of pain, we should examine the episiotomy before the discharge of the patient. That in the past 1 year, at least 3 or 4 times, I have had women with infected episiotomy. They don't know. They think the pain is normal. Pain is, it will be there anyway. And by the time we examine, the lady has had infection, like advanced infections. That should not happen. At least once we should examine the episiotomy. So that is very important. And so if we have used regular vehicle, especially thick ones, if we have used, we may have to remove the suture, or she may have a feeling of that suture irritating her. That may have to be removed. And at 6 weeks, we have to check for adequate wound healing. Then, so that is regarding episiotomy, the procedure, repair, and post-op care. Now, I badly wanted to share one picture with you. That is one very rare complication of episiotomy is necrotizing fasciitis. So with other speakers' permission, I would like to put one slide, especially Prasanna Madam, because it is Madam's topic, complications. Madam. Shall I?
Sure, madam.
Okay. So this is one very bad episiotomy wound which we got in my 23 years. I'm seeing it for the first time, so I badly wanted to share with all of you. And this lady, she was a second gravida. delivered, and 5th day discharged. She went home. Next day, she had severe pain. She reported to a local hospital. That is not where she delivered. And they immediately referred to us. So this was a necrotizing fasciitis type. Like 8 o'clock, by 5:36, she was in the hospital with all investigations, consultations, and all. We took her up by 12 o'clock. We could take her up only by 12 o'clock in the midnight. By that time, it was rapidly expanding. And this, I'm not sure if you're able to see, this encircled, this thing is the avulsed episiotomy sutures, too tight and long, thick vicral. Okay, some 3-4 we could see. It was the avulsed episiotomy. And here we had to cut till here. We have to do the debridement, and she had to stay in the hospital for some more than 3 weeks. Finally, we had sent plastic surgery consultation and all, but then always there was some organism. So they said only after infection clearance they could think of skin grafting or something. But then finally, without even skin grafting, she went home. So that is one slide which I wanted to share with all of you. How important it is, like examining the episiotomy, suturing it not too tight, and leaving the thread short. And this, I would like to thank Sadi and Dr. Vaishnavi and Dr. Adida for helping me with all the technical aspects. And these are my references.
Prasadi,
okay, thank you.
Initially, when I put complications of episiotomy, I put necrotizing fasciitis.
Madam.
And I thought during the last 45 to 50 years, I have not seen even a single one. So I thought
Yes, madam.
And my daughter also said, you cut it off, Mama. We are not seeing necrotizing.
Yes, madam. This
But
was like
I have not
rapidly.
seen. I have not seen.
Madam. Yes, 8 o'clock it had, 8 o'clock I had seen the patient, night shift had come. And by the time 12 o'clock we took her to the OPD, it was rapidly expanding.
Okay.
And it was like that pizza cheese, no? That thing coming off like pizza cheese, and E. coli was the organism.
Pizza cheese, are you?
Sorry. Because that waxy, that dripping waxy thing.
Okay. Well, excellent video presentation and the take-home points, Deepa, especially starting beyond the episiotomy, apex, and then catching hold of the bleeders and suturing it separately, or tackling the bleeders. Then actually doing PR before episiotomy and actually after, and also after episiotomy. Then suturing the bulbocavernosus muscle to prevent sagging, that separately. Before, to prevent sagging, and that's called crown suture. That is new info for me. And also documentation. Your point, that is episiotomy sutured in less and PR done. You have to, and also one point from Madam Prasanna Madam, that all mops, instruments, and all mops and needles count have been taken. Documentation is also important, and inspecting the wound before discharge. All these are very essential, very practical take-home points. Thank you. Over to Rajesh, and also expert Madam Sundari Madam for further comments. And also Senior Madam, sir. Yeah,
it was excellent. As you said, Sati, every point she has been brought out. Important things is, rectal examination, and then suturing, not tight sutures, just approximation. Probably the video I was seeing, whether there was a mucosal edema when she was suturing it. And then mucosa and submucosa have to be taken deep, but it's not a wide sutures. You should not take in the vagina, as she was telling. But I thought sutures must have been a little wide. But anyway, the edge of it, but the deep, so that submucosa is involved, is better. So that a minimum mucosa is taken into the sutures. That is important in the, especially posterior vaginal wall mucosa. And that point I learned from you, the bulbospongial muscle, how to do it, because I also always do it mucocutaneous junction. Then of course I go deep and then take the muscle and come out. Usually that muscle will, if you hold it, the forceps, not with the hands. One more thing I teach my students is, don't put the hands into the vagina and then try to see for the muscle and all. It will be very painful. So use the instruments and be gentle with the tissues. That's the other thing, I think. Otherwise, it was an excellent video. Plus, the points was very, very valid point she has brought out. Very nice. And the post-op, looking at the wound is very, very important before discharge. And even after discharge, they come, small gaping of the skin will be there in few people, especially when we do continuous. They'll come and they'll ask whether I need a suture again, madam. You only have to reassure them and say that for 7 days, don't widen your legs or sit cross legs. That is another important point I always tell the patients, so that the sutures will heal better. That's all. I think it was a good presentation.
Thank you, madam. Thank you, Deepa madam, once again for that effort for compiling such a nice video. I think we have come to the end of our session. It was such a fruitful session, I believe.
Rajesh, a few points can I have?
Sure, madam. Sure, madam. Please.
This is for just for the postgraduates. So it was an excellent webinar, and almost all the points has been widely covered. Just a few points for the postgraduates regarding the postnatal examination of the uterus. Whether the uterus is in the midline or not, especially madam told that the supraelevator hematoma. So don't leave these patients to the house surgeons alone. So see the uterus, whether it is in the midline, and if it is deviated to one side, one thing you have to see is whether the bladder is full. And if the bladder is not full, definitely you need to have a pervaginal examination done to rule out a supraelevator hematoma. Second thing is that when the patient is not passing urinary retention, you have to palpate the episiotomy hematoma. As I ask the people, they say it's a fluctuant swelling. Episiotomy hematoma is never a fluctuant swelling. It's a hard, indurated, tender swelling. So that has to be taken care of. And when the patient is sent to ward, the patient should be seen by a senior obstetrician or whoever has conducted the delivery. And as madam said, to combat all the medico-legal issues, you have to document the pervaginal examination, the rectal examination, whether it is normal or not, because we had 2 buttonhole injuries which was detected and missed, and then a colostomy had to be done, and that is still that case is going on. So it's very important, though it's a basic surgery of our profession. It is the most medico-legally complicated surgery also. Thank you.
Thank you, madam, for the wonderful words. Any more comments? Kunjumadin, sir?
Hello.
Yes, sir.
Yeah, it's a real great effort from all the faculty to compile all the details and specifically the evidence-based practice with regard to the episiotomy in the current period. Not like the past time where we used to put episiotomy for each and every delivery which is being conducted in the hospital. But as per the current evidence, it is only selective. So that has been very much highlighted. All the techniques, complications, the video demonstration, all were very superb. And big congrats to all the faculty and the organizers, Dr. Rajesh, Subhash, and all the team. Thank you.
Thank you, sir. Subhash, sir. Final words.
No, thank you, Kunjumadin, sir. Thank you, whole team. Thank you to all the faculties. I think, Rajesh, it's been a great effort from you. I think you've taken the initiative. You're the first opening batsman of this year's academic committee activities, and you have started with the sixer. Many happy for you, and congratulations to Satya madam, whole team, all the people who are behind you for this wonderful efforts. Again, I would like to thank all the senior members, Prasanna madam, Deepa madam, Uma madam, Sujamal madam, Sangeeta ma'am, Suchitra ma'am. Again, Suchitra ma'am, thank you very much, ma'am, for guiding Rajesh and this whole team. And Sundari madam, thank you very much. And Suja ma'am, thank you, ma'am, for your efforts and staying from starting to the end. On a lighter note, I started when I was in Vadagara, and currently I've reached Calicut Airport also. So that is so it's been a very wonderful. It's a very long one, but very informative. And to get 220 people for a webinar is not a simple thing. It's a lot of efforts. Thanks to all the present secretaries and all the societies. Kunjumadin sir, thank you very much for all the support and all the help.
Though you will not like to take the credit, it's all your efforts, sir. Thank you very much, sir. Thank you, sir. Thanks. Tanya madam, hi.
Thank you. Thank you.
So by that, I think
Rajesh?
we'll wind up the session. Once again thanking Kunjumuddin sir, Subhash sir for compiling this program and allowing me to start with the EDS webinar series. I thank every faculties who I joined, especially Sundari madam, Rasna madam, because they had come in between other problems also. Sundari madam has taken an effort between her tight schedule also. All the chairperson, Suma madam, Ansi madam, Sadhi madam, on all the 6 speakers. And I thank all the presidents of the societies for coordinating the events. Thank you all. Thank you once again, and thanks the Astia team for the platform. Bye. Good night.
Thank you, Rajesh.
Thank you,
It was wonderful, and I have done wonderfully well. Even organization was good, and audio visuals were good. So very well done. Thank you, and congrats for all the entire team. And I thank for involving me in this webinar. Thank you.
Thank
Good
you.
night to all of you.
Good night.
Congrats, Rajesh. It was a very nice presentation.
Thank you.
And being the first batsman, you had an edge over the others in this edge series.
Thank you, man.
കൺഗ്രാറ്റുലേഷൻസ് എല്ലാം നന്നായിരുന്നു. ആൻഡ് സംഗീത മാഡം എനിക്ക് പറയാൻ സമയം കിട്ടിയില്ല. ആക്ച്വലി ഭയങ്കര നല്ല എക്സ്റ്റെൻസീവ്, നല്ല ആസ് യൂഷ്വൽ ക്രിസ്പ്, ക്ലിയർ, ടു ദ പോയിന്റ്. വളരെ നല്ലതായിരുന്നു മാഡത്തിന്റെ.
Good night.
ഗുഡ് നൈറ്റ്.